Most welcome. Please, the Secretariat, let's do this very fast because we are supposed to begin at 9:30 and we are left with 5 minutes to do that. So please settle in, you're most welcome. We shall be starting this conference in the next 5 minutes. Please, my co-MC, Mr. Inoviona Emmanuel, come and say hello to our guests. You're most welcome.
Distinguished guests, participants, you're all welcome. As already introduced by my co-MC, I'm Emmanuel Ainebiona. I work as the Senior Public Relations Officer at the Ministry of Health, and we shall be your hosts throughout this conference. I hope everyone has gone through the registration process, and we are starting in a few minutes. Feel free to know your neighbor and also be conscious of security. Ensure that no one abandons a bag besides your seat, and endeavor to know who your neighbor is. Thank you.
So good morning, ladies and gentlemen. Thank you for coming, and you are welcome. We'd want to keep time to this time. If you are talking about quality, and time management should be one of the things that should be used to measure quality. We are already 5 minutes late, but that is within the margins of error. So I want to call this meeting to order. We'll be joined by the minister for the official opening, but we think we can start as we wait for her to come. So that means when she comes, then we shall start the national anthem. For now, we cannot do a national anthem before the minister comes. So what we could do in the meantime is we could start with a prayer. I want to believe somewhere in this big hall there's somebody who knows, who has a direct telephone line to God, and he could be a volunteer, unless somebody has been organized. If there's any pastor, priest, nun, or hajj, or sheikh, can help. I know somebody who prays very well. Can somebody help me to give a microphone to Dr. Bayo? How are we dealing with microphones? We have mobile microphones? Hey, here? Yes. Dr. Bayo, can you help us to lead us into an opening prayer this morning? And may I ask people who are please stand, take your seats so that the session begins.
Let's humble ourselves as we pray. Thank you, DG. Heavenly Father, we thank you. We thank you for life. Thank you for your presence in our lives. You created us in your own image, and in your likeness, you created us. Thank you for the dominion over every other thing that you have created. Thank you for this meeting, which is deliberating on quality improvement. Thank you, Heavenly Father, for Uganda, the peace that we have. Thank you for you will also help us to address other issues regarding safety. Thank you for the progress in our time. Thank you for this meeting. We ask for your wisdom. We ask for the spirit of unity and the can-do spirit that will help us to forge ahead with the recommendations of this meeting. Thank you, Heavenly Father, for your help, now and even hereafter. In Jesus' name, we have prayed.
Amen. Can we give Dr. Bayo a big clap? Good. Once again, good morning, ladies and gentlemen. I'm called Dr. Henry Mwevesa, the Director General, Ministry of Health. Now, in such a big meeting, it becomes a bit difficult to do introductions, and I want to believe we'll take a lot of time if we go into introductions. So, I don't know how to do it, but let's quickly recognize, see how to do it. Of course, we'll be joined by the minister. Dr. Bayo Fatumbi is representing the WHO country representative, and he's here with us. He's one of our technical advisors on malaria. We have the USAID Deputy Mission Director, and I want to request him to raise his hand for recognition, and all those from USAID. I want to recognize the JICA senior representative and all colleagues from JICA. Please put up your hands for recognition. I want to recognize, I'm starting with our, you know, when you are a host, you first recognize visitors. So I want to start by recognizing our visitors. I want to recognize our development partners. If we have colleagues from UNICEF, if there are any colleagues from other colleagues from WHO, if there are any colleagues from CDC, any other colleagues from PEPFAR, Good. Okay, any other implementing partners? Our implementing partners, I know you are many. Implementing partners, you are welcome. Any other development partners? We need to recognize. Development partners I have not mentioned who are here. World Bank. Anybody from World Bank? Okay. Now, senior colleagues from Ministry of Health, of course, I will start with the Director, Governance and Regulation, Dr. Joseph Okware. Any other colleagues from Ministry of Health, commissioners, assistant commissioners? Thank you. Then academia, our colleagues from the higher institutions of learning, universities, technical institutions, training institutions. If you're also around, you are welcome. But also we need to acknowledge that many of our colleagues are online. So there are very many people who are joining us online. We expect about 200 people in here and about 1,800 online if the system can handle. Civil society organizations, we also have colleagues from civil society organizations. If there are some, can put up your hand for recognition. And of course, we have our keynote speakers. Like this morning, I'm sure we are joined by Dr. Carlos Jave, and I'll be introducing him when he's coming to talk. So we have our program before us. Once again, I want to welcome all of you for coming for this 8th Annual Quality Improvements Conference, and I want to thank you for coming. I've already told you, we expect 200 participants here, but we'll be joined by 1,800 virtually. It is a 3-day meeting where we'll be starting with plenary presentations every morning in this hall, but then we have breakup sessions in 3 different halls, and that will help to separate us from the big numbers. While we are here, we need to strictly observe SOPs, especially we must keep on our masks. I think Emmanuel already said it. Management didn't provide for very sanitization in this place. I'll mark them down on that one. That mark, they have missed it. But at least let's try to keep social distancing. Of course, even the arrangement of seating is not the best I can talk about. We expected about at least 2 meters apart, but at least 1.5. I see it's almost 1 meter apart, but please try to keep on your mask. I want to believe almost all of us are vaccinated and possibly have tested negative. The theme, you all know our theme for this ICE conference, fostering delivery of quality health care in the context of COVID-19. So without wasting a lot of time, I want to invite Dr. Joseph Okware to give us the objectives of this meeting. And thereafter, we shall invite our keynote speaker, and I want to believe the IT people are already setting up with him. So please check that he's online so that as soon as Joseph finishes, then we can invite him and we are sure that he's available. You have the floor, Joseph.
Thank you. Thank you very much. Good morning. Thank you very much, Chair, Director General. Am I audible? Oh, this is a bit low. This is better. The guests, mission director, officials from JICA, WHO, our partners from UNICEF, CDC, PEPFAR, World Bank, colleagues, keynote speakers online, and those who might be here, because we have a few, I think two that will be speaking in the course of the conference, who might be here physically. And all of us, the health workers and the family of quality improvement in this country and in this region, I want to take this opportunity before I share the objectives to welcome you all to this annual event. For us as a community that believes and practices quality improvement, we hold this fora very dearly because it is an opportunity for us to really meet and share the challenges and the progress we are making. So this 8th QI conference is the second of its kind, in that, as the chair has said, it's more of a virtual event than physical for obvious reasons. The last conference we had was of a similar nature. We had more participants coming in virtually than physically, for reasons that you know. So we expect about 2,000. Tisha? What is this for? Okay, so we expect 10% only here, and the other 90% of the participants will be online. And we hope that our technology will serve us well. The theme, as has been highlighted by the chair, is fostering delivery of quality health care in the context of COVID-19. So in a way, we have dedicated this QI conference this year to COVID-19 because we know that it has taken a lot of our efforts all over to be able to respond to this global pandemic. So the broad objective of the conference is to share experiences, to share challenges and opportunities, and tested interventions in implementation of QI in the healthcare settings during this COVID pandemic. You can, I have a hard copy, you can help me. Okay, so objective. Okay. Objective number one, there are about 4 or 5 of them, is to share new QI innovations in the management of COVID-19 as the first objective, as we dedicate this conference to COVID fight. Then the second objective is to mobilize and advocate for support, resources from leaders and financing actors towards improvement of quality of healthcare during this COVID-19 pandemic. The third objective is to highlight policy issues and ideas for building resilient and sustainable delivery of quality care in the context of COVID-19. The fourth objective is to discuss the impact of COVID-19 pandemic on the delivery of quality health services and demonstrate achievements made so far in controlling COVID-19 spread. And the fifth is to launch a few documents for QI that we have managed to put together during the last 12 months. So we're going to launch our National Quality Improvement Framework and Strategic Plan. This is going to be the second one. The first one expired, so we have a new one. Secondly, we shall also launch our QI database, sort of a repository for our work that we're doing. And thirdly, we shall launch a new project that is going to be funded by government of Japan and government of Uganda. This new project, Mr. Chair, is going to focus on patient safety. This is an area that is quite weak in Uganda, and we think that with this project, which is going to be launched during this conference, we should be able to raise patient safety in our agenda in this country. So those are the objectives of the conference, and in the next 2 or 3 days, we should be able to cover all this. Thank you very much, Chair.
Thank you very much, Joseph. Good. So now I want to be guided if our keynote speaker is online, so that it's okay? It's online. Good. So before I invite our keynote speaker again, I want to echo what Emmanuel said about security. First of all, I was impressed by the checking at the hotel. There was good checking as we came in, and I think that makes us a bit confident. But despite that, let's make sure that you know who is your neighbor, and that if he's carrying a big bag, you may have to keep a close eye on that big bag. So, but at least I'm convinced most of our bags were checked as we were coming in. There's a hotel we were in last week, and I was not really very impressed by the checking which was going on. So each time I was in that hall, I just put my life in the hands of Jesus. So, ladies and gentlemen, our keynote speaker is Dr. Carlos Javier Cuellar. He's the Executive Vice President of URC, Washington. He has been with URC since May 2020. You recall before that, the Executive Vice President was Rashad, who was almost a family member here. Many of you knew him. Dr. Carlos replaced Rashad in that office, in that capacity. Carlos has experience from Ministry of Health of Bolivia, where he worked in different capacities, coming from the district through the ranks up to the national level. And after that, he joined other organizations like Abbott Associates as a vice president and senior fellow. He's a medical doctor, holds MPH, and a diploma in tropical medicine from Antwerp. He has also experience from very many countries where he has worked as a chief of party, but also as a policy advisor, and mainly in quality QI, in maternal and child health services, HIV and AIDS, and many other specialties, some of which were in Dominican Republic. But as you know, as a chief of party and the advisor, he must have traversed very many countries. Carlos has not been to Uganda, and it is a date on him. We want to remind him that, Carlos, you have a date to come to Uganda. Now the skies are open at the next Quality Improvements Conference. We expect you to be here or even before. We are looking forward to meeting you in Uganda, but we thank you so much for accepting to give us the keynote address. He did the same last year. And colleagues, as you realize, he's presenting from Washington. I think if it is 10 o'clock here, take away, I think 7 or 8 hours. 8 hours now. So that should be 10, take away 8. It must be 2 a.m. So we really appreciate, and we need to give him a big clap for foregoing his sleep in order to make this presentation. Carlos, I think this time we have tried. I recall last year we did very poorly. He waited for us at 2 and he presented almost, he was supposed to present at 10, he almost presented at midday. So, Carlos, you are welcome and you have the floor. Please join me to welcome Carlos and thank him for his keynote address. You have the floor, sir.
Thank you very much. I would like to confirm first if you are hearing me well. Yes? Okay. Good morning, everyone, and welcome to this knowledge sharing virtual forum that will contribute to an already robust conversation on quality improvement in healthcare in the context of COVID-19 in Uganda and beyond. Let me begin by thanking all you for your participation in this conference. I want to recognize the presence of and representatives of the Honorable Minister of Health, the Permanent Secretary of the Ministry of Health, the Director General of Health Services, the Director of Health Services and Governance and Regulations, the Director of Health Services and Clinical Services, Ministry of Health officials, the USAID Mission Director, the CDC Country Director, the WHO Country Representative, the JICA Representative in Uganda, Health Development Partners, distinguished presenters, public health leaders and practitioners, and the public health activists and researchers who dedicate their careers towards advancing quality healthcare delivery. Strong management enables the achievement of large ends with limited means. I will repeat because it's very important. Strong management enables the achievement of large ends with limited means. Assuring the sustainable financing of the health sector's activities and even increasing the funding for health in any country, essential and desirable result. But I would argue that financing alone is a necessary but insufficient condition to improve health systems performance, especially in times of an unprecedented global shock such as the COVID-19 pandemic. My message to you today is that management capacity is a key leverage point for high-performing health systems. Investments in strengthening management capacity can maximize existing financing mechanisms and a skilled and expanded health workforce. Human, technical, physical, and financial resources will never be enough without a strong management capacity. It's an undisputable reality that became more evident during the pandemic. The 2007 World Health Organization Regional Workshop on strengthening the management capacity of health managers at subnational and district level identified that inadequate delivery of healthcare services is one of the reasons for the low level of health status in many countries. In the same event, the public health community acknowledged that weak or managerial capacity at the national and district levels is one of the major bottlenecks in scaling up the provision of health services and achieving the Millennium Development Goals. As you may agree, it's common to find in low and middle income countries that health budgets, especially from loans and other external funds, are slowly executed. Expensive and sophisticated medical equipment are purchased but not utilized or are underutilized. And in some health districts, experience an oversupply of drugs where others face acute shortages. Most of these problems can be solved through a small investment in better management. Some of the challenges observed in most countries include shortage of managers, limited managerial knowledge, skills, and effective behavior among existing managers, high management turnover, lack of policy instruments, and managerial techniques and tools to improve performance and accountability. And finally, a lack of an enabling environment to support management development. Those challenges, aggravated by the COVID-19 pandemic, renewed the urgency of systemic and sustainable solutions, the need for global health security, the recognition of the stewardship role of governments, the growing role of local partners, the emergence of the private sector, and the active role of communities that will further shape the health and development landscape in low and middle income countries. So, why is good management critical? Substantial financial resources flow through health systems. Hospitals and other health facilities are complex operations, constantly challenged to maximize community and patient benefits with limited resources. The lower the resources to respond to the needs, the higher the need for effective management capacity to make the difference. Management capacity is particularly low in low-income countries, where the efficient use of scarce resources is paramount to attain health goals. Moreover, there is ample evidence globally that health workers' motivation and retention is highly influenced by the quality of management in their work setting. Yet, most health system managers in low and middle income countries rose to their positions based on clinical or surgical training and experience rather than management competencies. I repeat, strong management enables the achievement of large ends with limited means. In just every human enterprise, good management is fundamental to high performance. Although the importance of management is well established in private industry, its role in healthcare has been overshadowed by the more visible clinical roles in healthcare organizations. To develop robust field of management in national health efforts, we need to consider what are the core competencies required to effectively and efficiently manage, and which steps should be targeted for management capacity building. At this point, I want to advocate for 8 core competencies in management of national health efforts. These 8 core competencies align with health management competencies more broadly, but include domains that can be tailored according to resources and care settings. While the competencies apply across all levels of management, the level of control and portion of time spent in each area will vary based on the structure and level of hierarchy within the larger health system. The 8 competencies are: 1. Strategic thinking and problem solving. 2. Human resource management. 3. Financial management. 4. Operations management. 5. Performance management and accountability. 6. Governance and leadership. 7. Political analysis and dialogue. And 8. Community and customer assessment and engagement. Let me talk a bit about each competency and why I believe each is critical for improving the performance of Uganda's health system. First one, strategic thinking and problem solving. It refers to the ability to set an objective, calculate risks, and align resources for problem solving. Thus, the organization may be well positioned to achieve its goals. This competency requires an ability to see the connections among elements of the system and understand enabling and impeding forces in the alignment of resources and objectives. Skills within this domain include defining a problem and setting objectives, conducting root cause analysis, making comparative alternative strategies, planning implementation, managing friction and dissent, and evaluating outcomes. Within human resources management, we include skills in recruitment and retention, employment, education and training, compensation, employee relations, motivation, and performance evaluation and mentoring. The competency of financial management encompasses budgeting and budget variance, analysis, financial accounting, and capital and project evaluation. Operations management activities vary based on the organizational form and function. They may include patient registration and flow, patient master index and medical records, environmental services, supply chain, pharmacy and lab management, patient referral and discharge process, payment processes, cash flow tracking, and information technology. Performance management and accountability may include logic models, process and outcome measurement, balance scorecards, community scorecards, quality improvement, and data feedback and accountability systems. Accountability may include ensuring performance to both internal and external constituents within the health systems and community at large. Governance and leadership refers broadly to creating facilitative environments and engaging with others to achieve group objectives, and may include, but are not limited to, conducting governing board activities, developing organizational and corporate cultures, and ensuring succession planning. Policy analysis and dialogue comprise understanding political and regulatory environments, making policy trade-offs, conducting stakeholder analysis and advocacy. And last but not least, community and customer assessment and engagement include epidemiology skills, survey techniques, community-based participatory research, health education and marketing, understanding the customer, and having a customer service orientation. Managers can fulfill these competencies by direct implementation or by creating an enabling environment in which others can execute these activities effectively. Who needs to develop these competencies? The roles targeted for management capacity building are most fundamentally middle managers, including facility-based staff and policy or regulatory staff who oversee these facilities. Middle managers are crucial to translating the top-level policy and strategies into practical improvements at the front line in healthcare and health promotion efforts. Facility-based middle managers include hospital or health center directors, chief executive officers, and management team, including clinical managers. District and regional health teams also require enhanced management capacity, as they often supervise facility-level management and have their own programs and projects to direct. Although practical examples, particularly within the operations domain, might vary depending on the type and location of the manager, the 8 competencies are relevant to facility and district or regional management as well. Clinical and admin staff can benefit from enhanced management capacity and form a cadre of people who translate ministry level and global strategies into practice at the front line, while ensuring information from the front line is recognized in high-level strategy development. Despite the limited published literature on the contribution of management to health system performance, several lessons emerge. First, country engagement and ownership of management capacity building efforts are necessary for national healthcare delivery and population health improvements. Improving management challenges the status quo and may trigger changes to multiple systems, including procurement processes, hiring and evaluating staff, and managing budgets. Additionally, empowering middle managers to think strategically and problem solve can upset traditional hierarchies and power structures in the name of efficiency and performance. Hence, while external technical inputs are helpful, internal political leadership is essential to address and manage inevitable friction with transformational change. Second, management capacity building takes time. It involves the development of habits and cultures that are more transparent and accountable. Although some short wins are possible, interventions should provide continuous support before documenting strong management and performance improvement. Third, management is both an individual capacity and a system-level capacity. Hence, while individuals and group benefits from mentoring, coaching, and providing technical support for system redesign and performance measurement, these interventions are likely to be most effective when supported with adequate institutional design and financing as well. In many cases, although turnover of individuals can be challenging, management capacity can be institutionalized by valuing management positions in the healthcare sector and establishing educational programs to equip staff with management tools and skills. A 3-part strategy is needed to build the field of management as a key pillar of national health. This strategy incorporates training for education, practice, and research. In the area of training and education, curricular management offerings that impart knowledge and experience regarding the 8 competencies are needed in undergrad and grad degree programs globally. Although some exposure to management concept would be helpful in medical, nursing, and other clinical and public health programs, specialists with extensive management education are also needed. Examples of such programs can be found in the Master's Hospital and Healthcare Administration programs in the United States, Rwanda, and Ethiopia, as well as in Master's and Bachelor's of Public Health programs with management concentrations, or Master's or Bachelor's Business Administration with healthcare concentrations. Ministry of Health support for such programs and requiring some management education to perform key health management positions in hospitals, health centers, and districts or region would go a long way to improving management capacity in a country's health sector. In closing, I believe the field of management holds a promise as a fundamental leverage point for national efforts to achieve health system performance goals within existing technical and financial resources. The field is comprised of these distinct competencies and key facility, district, and regional positions with management responsibilities that can be identified that will most benefit from management capacity building efforts. The evidence base supporting the role of management in performance improvement is consistent, but would always benefit from additional research with improved methodological rigor and longer-term horizon investigations. Meanwhile, greater emphasis on management as a key leverage point for health system strengthening may open new and sustainable avenues for advancing quality healthcare and overall health system performance in COVID-19 times and beyond. Thank you very much for your attention.
Thank you very much, Carlos. Another big clap for Carlos. He has taken us through strengthening health systems during the COVID pandemic and beyond. And as you heard, he highlighted and emphasized the importance of managing resources, that resources will never be adequate, even in developed countries. Looking at human resource, financial, even essential medicine and health supplies. He emphasized the role of QI and also the importance of the private sector. I don't know if we have some comments. We still have a few minutes. I don't know if Carlos can take a few comments or questions. We could give it some 5 or 10 minutes. Is that okay, management, as we prepare for the next session, as we wait for the minister to come? Because the minister was meeting a WHO delegation, which is in the country on mental health services, and she was meeting them at the Ministry of Health. I've just been talking to the personal assistant, and she said she's about to leave, considering that she has a lead car. We anticipate that 10 minutes will be enough for her. But sometimes you also get in a jam where even the lead car is useless, you even just switch off. But I believe at this time it's not so bad. So, Carlos, is it okay if members made some comments or asked a few questions? Or yes, you want to catch up with your sleep? Is it okay?
Yes, it is okay.
Oh, okay, thank you very much. So, colleagues, any comment or question from members? Somebody with a microphone? Anyone with a microphone, please? Anybody who has, if I'm not seeing properly, somebody can guide me. I think the presentation was very clear and very well appreciated. I don't see so far any comment in the room, unless sometimes we forget people online. Who can help us with the people online? How do we? IT. But first of all, you have not showed me if actually our system is working and people are online. Is it? Okay, there's a hand there. Yes, sir.
Thank you very much.
Yes, sir.
This is Ekelot Isaac from Soroti region. I'm Assistant Nursing Officer, Psychiatry. I work at Princess Diana Health Center 4. I'm also a regional QI coach for Soroti, Kalaki, and Kabremaido. I have been touched by what Dr. Carlos emphasized, and I just wanted to say something in line with that. Strong management enables in achievement of large ends with limited resources. And one of the things that he added in between there about management capacity of health managers is key in good progress the health sector. And the other thing I also noted was lack of enabling environment for the managers. And it is one of the things actually affecting health sector so much. And for an in charge of a facility who has identified an issue and forwards to the next supervisor, it is usually a challenge. That at the end of the day, an in charge who has been given to take charge is not supported by the next ladder or the next step. And I don't know how we shall get out of this, because a number of in charges, if one is in the house here, will actually agree with me that you could be given the authority, but when you exercise your authority, you could be blamed at the end of the day for exercising such authority. So as health sector, it's one of the areas that we should support the managers, and I have personally taken note of this, and I felt I needed to re-echo. Thank you very much.
Thank you very much. I think that's a comment. Any of us can comment on that, but if Carlos also has something to add to that, it is okay. But that was a comment, it was not specifically a question. Any other comment? Good, that's what happens. Normally it is the first bullet which is difficult. As soon as the first bullet is short, yes, sir, there's somebody here, then there, yes, it's okay. The one with the microphone is, start from there since he's nearest the microphone. Just a short introduction and your question or comment.
Thank you, Chair. I'm Dr. Batesach Agre, Assistant Commissioner, Inspection and Compliance. In addition to my colleague from Soroti, Dr. Carlos mentioned the management at all levels. In Uganda, in fact, this morning, Mr. Chairperson, we've been discussing with someone from subnational level, a manager at subnational level, and we are discussing challenges of management of health services at that level. My question to Dr. Carlos or anybody in the room, how do we support our managers at subnational level and their managers there to be able to support these managers to do their role? I'm just asking this in line with the guy from, the colleague from Soroti, that there are challenges there, and many of the challenges in Uganda affecting managers is at that level. How do we support the managers there and their managers to be able to deliver good management for quality service delivery? Thank you.
Thank you. So is that for Carlos or for Kware? That question, agree. Your question is to all of us. Is it to Carlos?
To Carlos, because to Dr. Carlos, because in his introduction he worked at those levels.
Okay.
Thank you.
Thank you.
Thank you so much, Chair. My name is Michael Adrawa, Assistant District Health Officer in charge of maternal child health from Moyo. This question goes to Dr. Carlos. With his immense experience, how can we mainstream the different, he mentioned of 8 core competence for management capacity in the different levels of management? In the case of Uganda, thank you.
Thank you. Yes, sir. Unfortunately, because of masks, I can't know who it is, but there's a colleague with his hand up there.
Thank you, Chair. Dr. Vamwine.
It looks like Ivanda.
Yes, Director. My question actually
No,
was-
Dr. Vamwine, you need to introduce yourself properly.
Yes, I'm Dr. Vamwine Julius. I work in Ivan as a DHO, but at the same time, I represent the DHOs from Southwestern region in our association. My question goes to the Director General. We used to have a program which would actually support HSD managers. They would be taken for at least 2 weeks course in management skills, usually at Uganda Management Institute, and this usually to help us. I don't know what happened. Could it be put back? Thank you.
Thank you. Is there another question or comment? Yes, sir. Is it? Hey, madam?
Yeah, I am Maureen Tuchize Dabanji from Right Southwest, USID Right Southwest. Just a quick question for the DG. What happened to the appraisal system for the DHOs, the facility in charges? Who appraises them? Do we have any form of accountability for their performance? Because Dr. Carlos has talked about performance management. So what is happening in the appraisals? Thank you.
Good. I've also got a question now. I opened it up for myself. Yes, sir.
Yeah, I'm John Maogole from Kabaramaido district, Kabaramaido Hospital. I have a challenge. There is that disconnection, because in the 8 cores that have been expressed by Dr. Carlos, there is that bit of the political area. You realize currently there is that gap between the health system and the politicians, whereby health workers are looked at in a different picture. There is no connection. You realize that the gaps that may be in the health sector may not be covered up, because the views of the health workers are not considered. You realize that the politicians may be taking what they think, but the reality is not taken up. How can that be covered?
Okay. Good.
Okay.
I think the Director Governance and Regulation will help me with that one, especially considering our relationship at the district level between the technical team and the politicians.
Okay, ladies and gentlemen, good morning. My name is Patrick Ogwok from Masaka Police Health Center 3 in Masaka City. My question is, I felt like now police as a department, we have now a health department under police, which is also giving the similar services like any other services given at Ministry of Health. But I feel like in the mainstream services for police health services, I feel like they are always being left out. For example, in capacity building, I'm glad that I've been in the police services, police department for at least 10 years now. We used to have our IP, which was supporting us in training, and now we have Rakai. But in the mainstream services under the DHO, we are always I think we are always left out in training. It's only the personnel who look for their own ways of study or adding the capacity. I want to thank you very much.
Thank you very much. Do we answer first before we pick more? Or we first speak? Or we conclude? Are there still many? Any more questions or comments? I think, I was told there are some on the online. Kakara, you told me there were some questions online.
so much, Dr. Carlos, for your presentation. My name is Egesa Harriet Margaret. I work in Tororo District in Mukuju Health Center 4. I'm a midwife. I appreciate Dr. Carlos for the elaboration of the competencies for improving Uganda's health. Something which touched me was the issue of human resource management, and he talked about recruitment and retention. He also talked about employee motivation. Now, mine goes to Ministry of Health. What is Ministry of Health going to do in order to retain health workers as far as the employee motivation is concerned? Because most of the health workers are leaving, especially public service, to go into private because of the issue of employee motivation. Thank you very much.
Okay, thank you, Margaret. We shall attempt to answer your question. That's not for Carlos, it's ours. Any other? Alex? Good. So I think we can give Carlos the opportunity to respond to those issues he thinks he can respond to. Then we shall get back to the hall, and we try to respond to the questions which are specifically for Ministry of Health and the districts. Carlos, you have the floor.
Yes. Yeah, thank you so much. Yeah, on the first question on how we support managers, I think if we really want to build a system, I'm a strong believer that training is not enough. I mean, we all have learned this lesson in the sense that when we set up training programs and we call it capacity building, it's just an exercise of providing tools and skills that cannot be applied when the trainees return to their regular jobs. I think we need to go beyond providing tools and training, which is important. I think we need to give managers the knowledge, the skills, the tools. However, this needs to be part of a performance management system, to be part of a structure in which management is possible, and then a structure that provides the not just the authorities, but also demands the accountability. So if we want to support managers, in addition to training, we need to delegate authority. We need to provide actual delegation of authority, and to clarify what are their areas of decision making, and give and empower them in a sense that they can respond to the needs of in terms of decision making. On the other hand, I think it's important to have an accountability system. For instance, having key performance indicators that will will focus the work of managers, providing with a system that will gather and analyze data. And as you know, data is important to focus our attention and to drive specific actions. So my short answer to this would be, training is not enough. We need to set up a system that is conducive to good management, that includes delegation of authority, governance, key performance indicators, and the ability to gather and analyze data that will guide our actions and decisions. That would be on the first one. On the second, regarding the 8 competencies, I think we need to look at them in broader terms. I mentioned that each of these 8 competencies are not equally important for all levels. I would say that for national level, for instance, the political analysis and dialogue competency is more important than for, let's say, a district level. However, at the district level, also it's important to understand what's called the political economy and using political economy analysis tools to understand what is the situation. But that competency is more important at the national level. So what in my view, what we need to do is to look at these competencies, these 8 competencies, and say, okay, for a regional level, what are the competencies that I want that I need to do on my work, or what are needed for the national level. So we have to be to do the tailoring according to the reality of the country, according to the context, and according to the level in which managers are being exercising their roles. Thank you.
Thank you very much. I think now we can attempt to answer some of the questions which came to us as the Ministry of Health. My colleague here, Joseph, will try to help me answer the issue of the training of health sub-district managers, what happened at UMI. Can we try to reactivate that? We could also try, you could also make a comment, I will also make a comment on the appraisal system of DHOs and how we can also bridge the gap between our technical colleagues in the district and the political leadership, especially where you find that the political leadership may not be listening to the priorities of the district and not listening to the technical team, and therefore may be looking at the health services within the context of their political interests rather than the district health plan. Masaka, we could also answer that immediately regarding the police medical services and how we interact with the Ministry of Health. And then I will respond to the Tororo Margaret about motivation of the health worker in the district in general. So you can start. You have a microphone? Yeah.
Thank you very much, DG. And we need to appreciate Dr. Carlos for the talk that has caused this discussion. And I thank the audience for being attentive this morning. This was the first talk today, but you have raised the pertinent issues arising from what the keynote address has been about around management. I think the first issue was really sharing frustration that comes with management and leadership. And I think the member was sharing that at subnational level, he has seen a lot of frustration among managers at that level, at health facility level, at HSD, and even at district. And I want to say that management itself is really to deal with complexities. So when you're a manager, you have to be ready to deal with all these complexities. A lot of things are complex there. And when you're a manager, you go with competencies to hustle through these complexities. There are many layers, there are levels of mandate and roles and responsibilities. And as you work through your mandate, there is also the issue of the environment and the climate and the context, which Carlos has just emphasized a short while ago. And that sometimes comes with frustration. And I want to say that this frustration is not only at the subnational level, even at national level. The moment you're working within a system, that system, by definition, is complex. So I think you just do what you are required to do, and then you provide all the necessary information for the next level to do what they are supposed to do. I'll share with you, yesterday we were meeting the president, but at some point he was also expressing frustration because he was saying his idea, his feeling is that scientists should be paid well. I think you have heard about that. And he has told the people responsible many times to pay the scientists of Uganda, including health workers, better pay. But this is not being done as fast as he wants. So you feel that he also feels that there's somebody not doing what he wants to be done. So management and leadership is not selling ice cream. It comes with that frustration sometimes, but that's the reason why you are prepared to manage and to lead. You expect all this to happen, but normally with experience, you find a way of working your way throughout. That ties up with the concern from Dr. Bamwine from Ibanda, that for a manager to, for example, district level or HSD level, in the past we had packages for them. We had courses that would be run periodically for managers to be sharpened, prepared to be able to face all these hurdles that come with management. And he highlighted a good example when some courses would be run in the Management Institute, but this sort of died out. So he's asking why we have stopped this. And Chair, we are trying to revive this. I don't know whether the HR team is here, but I'm aware that during the restructuring of the ministry, we created a Department of Human Resource Development, HRD, and I think we have recruited an assistant commissioner, and soon there will be a commissioner for that department. And the idea is to revive the Health Development Center in Mbale, which would sort of revive that kind of support to build capacity of managers at different levels. But I agree with you, it's very important to support the health workers whom we place in management capacities in our health system to be able to do. Because you pick a doctor right from internship and you post the doctor to a health center and head-on, they begin facing these issues of management. The appraisal system and especially at the district, really in the health system, is guided by the standing orders and all those documents from public service. I think the point here is that they are not very, very good because eventually they are they are not done well. They are taken as rituals that you just do an appraisal once a year. Many times the individual feels their own output and performance, and the person that is countersigning does not check, does not sit with the appraisee to be able to say, let's plan for what you are supposed to do in this period of time. Then when the appraisal comes, you engage the appraisee to check whether the appraisee has really achieved as you had planned, and then score accordingly. So this all needs to be revived, and I know that the Minister of Public Service, in the current Standing Orders 21, you can get a copy from their website. They have changed a few things in as far as appraisal is concerned, and they have showed that they are going to come up with a better mechanism to do this. But for sure, our appraisal system in the public sector needs some bit of improvement if you compare with the appraisal in the private sector and in the corporate world. So there's an issue there, which we agree that the person who raised this is spot on, and we need to work together to be able to handle this. Chair, I think those were some of the questions. Thank you.
Thank you very much. I think we need to conclude very soon. I'll make some comments. I've just been advised by the minister that she's requesting for 30 minutes in order to arrive. So what we'll do, we need to conclude this session quickly, go for tea break, and then come back in time so that we use slightly less than 30 minutes, so that by the time she comes, we are here. So if that is agreed, I'll just make a few comments also, just to add to what my colleague has said. I also want to agree with the DHO, Eva, and Dr. Bamwine, that we really need to strengthen the management skills of our staff, especially at health. You need to mute somebody. Especially at health sub-district level, many of those in charges, especially the doctors there, are young doctors who have just joined, and some of them have not been in management capacity. What I can advise is that almost all districts in this country have implementing partners, and many of those implementing partners are covering regions. So I would want to request that implementing partners, and many of them have a component on management. So I would want to request that we will liaise with our implementing partners and organize a session for our in-charges, for our health sub-district in-charges, but even we could do for Health Center 3, in-charges, take them through a session 1 or 2 days, or at least 2 days minimum, on management skills, just to know how to manage resources, how to manage even our equipment, to manage our human resource, to manage, even they have finances these days. Those health facilities have finances, like Health Center 4s have good money, some from RBF, some from the partners themselves. So we can take them through a quick session of building their capacity and management skills. I agree with you in terms of the issue of appraisal. Of course, the DHOs are appraised by the CAO, but we are trying to build a system. We've been discussing it at the ministry level, because the CAO really looks at only the management issues. But for a DHO, there are also technical issues in which he needs to be appraised. And we want to build a system where some technical person is able to support the CAO in order to appraise the DHO. Because if you are going to leave the DHO to be appraised by the CAO only, the CAO will only appraise whether the DHO comes on time, whether the DHO is usually, like really he will appraise only the management aspect, but may not appraise the technical aspect of that DHO. So we are trying to work out a system of how to appraise them jointly, or give our aspect of the technical aspect of appraisal to the CAO to add to his management appraisal. Otherwise, at the national level, for us as a ministry, we appraise national referral hospitals and regional referral hospitals, and of course, staff of Ministry of Health. Kabaramaido, I want to say not only Kabaramaido, but all districts, where you find there is a conflict between the technical team and the political leadership. Sometimes it's good to let us know so that we can come in and guide you and support you, because we really don't want a situation where our technical staff have conflict with the political leadership. Because in that case, there's a lot of things really don't move. And if from what we have seen from our annual performance reports, districts where there is stronger leadership, there's a very good output, very good outcome indicators, and things move. And sometimes the role of the political leadership is very important and very strong. So it is important for us to come in. You may not tell us we are fighting here, but you can tell us when we come in, we shall not say, why are you fighting our technical team? But we shall get a way of harmonizing and supporting you to make sure that we narrow the gap of conflict between the political leadership and our technical staff. Masaka, I agree entirely with you. I know that even police, health, medical services, even the army, they even treat other patients or, health, or other clients who are not necessarily police or what. So we work as an integrated system. So let's say the DHO of Masaka should always include the police medical services in the training, when you have trainings, when you have services like vaccination. So they are part and parcel of the national health services, part and parcel of the district health services. So we need to work together as a team. Do not look at them as police medical services, as UPDF medical services, prisons medical services, but in terms of service delivery, we work, well, I know they have their resources, but in terms of capacity building, we can incorporate them. In terms of common services like vaccination, we provide them with services, TB services, HIV services, we should integrate them. Finally, in Tororo, and of course this doesn't only apply to Masaka, it applies across all districts. Let's say if you have UPDF medical services in Gulu, you work with them, just like I've talked about Masaka. Margaret, how do we motivate our staff? We motivate our staff. I want to believe, Margaret, you are not looking at motivation in terms of money. You are looking at motivation in terms of many other aspects. We motivate our staff through building their skills, capacity development, training, on-job training, through supervision. That's part of motivation of our staff. Provision of accommodation. I know only about 40% of our staff are accommodated, but it is our deliberate effort to make sure that we provide accommodation for our staff as part of motivation, and also as part of making sure that they respond quickly to any emergencies, but also they arrive at work in time. Promotions where positions exist is part of motivation, and we try to do that where positions fall vacant. Of course, now we are looking at enhancement of remuneration. That is going on gradually. But also, you know that government has also provided some lunch package, lunch allowance to our staff, and that is also part of motivation. But I also want to believe that one of the biggest or the strongest motivation to our health worker is service delivery. If I'm in a delivery room and I deliver a mother and give her a very healthy baby who goes home smiling and the mother healthy, that to me is a very, very big motivation. If I get an anemic child who comes into my clinic almost collapsed, and I resuscitate that child and goes home laughing and smiling, a child who was collapsed yesterday, and I discharge that child after 3 days playing around with the other babies, that to me as a health worker is one of the biggest motivation. If you get a severely anemic mother with complications, and you resuscitate that mother, and you save her from maternal death, I don't think there's any big motivation to a health worker than that. So there are very many factors that motivate us as health workers, and I want to believe, Margaret, you are not looking at money alone. So ladies and gentlemen, thank you very much for this session. I want you to join me to thank Carlos for a very, very good presentation, and very good presentation at this time. I want to thank him in a special way for missing his sleep. It must be coming at 4 a.m. in Washington, but we appreciate you. And join me, colleagues, to give him a very, very big clap. And hoping that next year he will join us and present from this place. Thank you very much. Now, I have a small challenge. The mission director is requesting to make his statement, but then it makes it a protocol problem because the minister would want to listen to your statement. So you may have to request somebody you are living in your shoes to make that statement on your behalf. Because to receive a statement from a partner, I don't know, I can be guided, but I'm looking at, we have only 4 statements. Already the guest of honor has missed the keynote speech. So it leaves us only with the mission director, the country representative, and then the PS to invite her. Mission director, if you have a written statement, you can't leave it somebody to read it for you, like Dr. Sayu, or the protocol doesn't allow. Okay. So, ladies and gentlemen, can we take a break and make sure we are back? At exactly 11 what? 11:20. 11:20. I want to believe the tea is around here. In the event that the minister arrives earlier, we can summon everybody back. Thank you very much. Thank you very much, ladies and gentlemen. That ends our session here.
Another round of applause for the chairman. Yes, Regina, thank you very much. Ladies and gentlemen, the tea is downstairs. And as the chairman stated, let's be back into this hall at 11:20. The tea is just down here, facing the garden area. Let's all slope down and be back in the next 20 minutes. Thank you very much.
one
Oh, not there. Ladies and gentlemen, the minister has arrived, so we need to take our seats.
The ushers, please. Could you usher in all our guests? The ushers, please. Let's usher in all our guests and we take our seats. Could we all take up our seats, please? Distinguished guests, we are still going on with our morning session, chaired by none other than our Director General, Dr. Mwebasas Henry, and the Minister has arrived, so we all take up our seats and we continue with our session.
Thank you very much. Our distinguished participants shortly will be joined by the Minister of Health. I would wish to take this opportunity to welcome you back from the short tea break. I hope we've been re-energized to enable us go through the rest of today's program. And I would wish to still emphasize that be mindful and conscious of your security because there are scares, so security remains one major priority, but also not lowering the guard as far as the COVID-19 preventive measures are concerned. We shall be having the official openings shortly when we are joined by the Honorable Minister of Health. And we shall have the national anthems as soon as the Honorable Minister arrives. Then it will be preceded by the official opening. Thank you. Ladies and gentlemen, the Honorable Minister of Health, Dr. Jane Ruth Achelo. Ochelo is with us. Let's welcome her. Honorable Minister, you're welcome. Yes. We can now raise for the national anthems. Thank you. We can take our seats, and I hand over to you, Director General, to update the Honorable Minister about the earlier activities. Thank you.
Thank you very much, Emmanuel. Honorable Minister, thank you so much for coming. We appreciate that you committed time amongst your very busy schedule to be here. Honorable Minister, allow me to invite the WHO country representative, somebody representing the WHO country representative, Dr. Bayo Fatum, to join us. Madam will also be receiving a statement from USAID Mission Director. He was here, but he left because he had another appointment. So somebody will be joined. Bayo, I think Bayo come this side so that we balance. Come this side. So that we try to social distance a bit. Okay. The mission director will be represented by somebody online, and I think Martin will make a statement from wherever he is. So, Madam, we've had the national anthems, the national anthem and the East African anthem. We had a prayer before we started, so I think it will cover us, even in your presence. So we'll be going direct to the program, and our program will be that we shall have Martin taking us quickly through this program. Already we've received the objectives of this meeting from the Director Governance and Regulations. But just quickly to highlight that we have here very many representatives. We have representatives from our partners. We have WHO country representative and a team from WHO. We have members from the USAID mission. We have representatives from JICA And they are represented by the senior representative for JICA in the country. We have partners from CDC, PEPFAR, World Bank, and UNICEF. Of course, we have our colleagues from Ministry of Health, and we have the Director, Governance and Regulations. We have commissioners, Martin Sendiona and other commissioners and assistant commissioners. We have a number of IPs who are here represented. Maybe you can put up your hand for the recognition. We have representatives from the academia who are also here with us. We have representatives from civil society organizations who are also part of this assembly. We have keynote speakers. We've just had a keynote speaker who was part of the opening ceremony, which started with a keynote speaker by Dr. Quela Carlos, who is the Executive Vice President of URC. He made his speech from Washington. It was, I think, around 2 a.m. in Washington, but he committed time and was here to make a keynote speech on strengthening health systems, even amidst COVID response. So we've received that, but just to quickly highlight that this is the 8th annual QI conference, which you are very familiar with. I think you have officiated on all the 8, either as a minister or as a director general, and we appreciate that. So this is really a conference which you are very familiar with and which I know you support very dearly and entirely. Honorable Minister was supposed to be in the field somewhere in the north, but she said, no, we must have participate in this QI conference first before going, and I think she deserves a very big clap for that because she really prioritized this conference. We have about 200 participants who are physically here, and I can guarantee you that we are trying our best to observe SOPs. And may I remind my brother there who doesn't have his mask on to quickly put it on. We are trying to keep a social distance and sanitize. We have sanitizers on table. We have about over 1,000 delegates who are following us online, both in country and internationally. We are here for 3 days. Every morning we start with keynote plenary presentations, followed by breakup sessions, and each day there will be 3 breakup sessions in the morning and 3 in the afternoon. The theme, you already know, Honorable Minister, it is with you. I've already told you that the first keynote speech was received from Dr. Carlos. So I think that is a brief about this morning. After the keynote presenter, there was some discussion of the topic on strengthening health systems amidst the COVID response. So at this juncture, I wish to invite Martin. Martin will be taking us through highlights of this meeting and the important documents that you'll be invited to launch, Honorable Minister. After Martin, we shall be inviting the statement from the USAID Mission Director, who, as I said, will be online, and that will be made by Madam Catherine Owens, who is the HIV/AIDS team leader. And then that will be followed by WHO country representative to make a statement, and I will be inviting you to address the meeting on behalf of the PS. So thank you very much. Martin, you have the floor.
Thank you very much, DG, Honorable Minister, the DG, all of delegates here in your different capacities. Good morning to you all. My name is Martin Sendiona, as I've been introduced, and I work in the Ministry of Health, and I'm in charge of the department responsible for quality of care. It is referred to as standards compliance, accreditation, and patient protection. Honorable Minister, this morning we are happy to stand here to launch 3 items. The first one being the National Quality Improvement Framework and Strategic Plan 2021 to 2025. That copy has been shared with you. As you came in here, make sure you have a copy before you leave this place. We are going also to have a launch. The minister is going to launch for us the database, Integrated Continuous Quality Improvement Database. I wish we could have the slides quickly. And Honorable Minister, the National Quality Improvement Framework and Strategic Plan is a document you are all familiar with. This is the third edition we have. And all the things you are going to do, as far as quality improvement is concerned, in this document. And I would like to request all people, stakeholders who are here and those in the field to really acclimatize yourselves with the document and make sure we use it as it is supposed to be. The goal is really to make sure that we have effective and harmonized implementation of quality of care interventions across the country so that we can meet the expectations of our clients. That's the main purpose. Then we have 6 objectives. I'm quickly run through them. The first one is strengthen leadership, accountability, and functionality of the committees. When I talk about the committees, many of you are familiar with this. We want more active and functional committees. We want them to be supervised, we want them to be monitored, we want the capacity to be enhanced. It has been lacking for the last period, and I think we can do better this time. Secondly, we are going to have to improve the implementation of health service standards. We've been doing health stakeholder assessment in our many facilities. We are going to do this time more systematically and also make sure that we link this with quality improvement. So we need your support and involvement and full participation. Chair, the third objective is the client-centered focus. We need to strengthen the role of involvement of the clients, the community, to get feedback, to conduct client satisfaction surveys. They are going to be more frequent, especially in the regional hospitals and in the districts and big centers. We get issues from the clients and we address them. Most important, the management has to handle that. And number 4, Chair, we are going to also focus on patient and health work safety. Chair, before I leave this, as I finish my presentation, you allow the JICA team, they are here, and we are going to launch the patient safety project. And they will come and explain more about it. But of course, certainly we are going to continue to be more focusing on the patient safety, infection prevention and control, which are still a bit lacking in our health facilities. Then we are going to do monitoring. Number 5, we are strengthening quality improvement, and 5S, monitoring across the sector. We are going to launch the 5S and the CQI database to focus more on the documentation, data collection and analysis, and use at different levels. So in the coming 5 years, that will be a key point of focus. Then the number 6, last but not least, we shall do more on the research and interest people in innovations. So the learning sessions and sharing of information at various levels will be the key issues of focus. Chair, those are the key issues we are going to have for the National Quality Improvement Framework. We are going to disseminate this document, shall come to you in the regions. Remember, this time around, we are working more closely with regional hospitals to reach the districts. So we welcome you and want you to plan and prepare for that. And of course, with the partners and other stakeholders. Chair, allow me to appreciate the task force which did this work, for the consultant, Dr. Herbert Mayanja, and also appreciate the partners, particularly URC, USAID, and the CHAI, Clinton Health AIDS Initiative, WHO, and UNFPA, to mention but a few. Very briefly, Chair, allow me to talk about the integrated continuous quality improvement database. It's a new development, and it's going to allow us really to be more, to work with our projects and the data and interventions for quality improvement. We do the tracking, we do the documentation, we do the reporting, and use this data from the smallest level in the wards, in the facility. That's our expectation, and we want a lot of support from you. We are going to have more 5S. The Light Client Satisfaction Survey brought out the concern about the situation in our facilities not being really conducive. So we need to do more about 5S and have more projects available and identify areas for change. But more so, we are going to do more documentation and have data available and use it. The ministry is going to work together with you to see that these things happen and they work. Most important, I underline the word working, and we shall depend a lot on you. So we are going to target all levels of implementation from the facility, community, starting from the community, facility, district up to national level. And then we shall, of course, certainly want to roll out full blast. That's our plan. We want to start all over at once. So you need to support us and want to appreciate CDC and METS and other partners who have really worked on this to make it available. Chair, that's what I have, but kindly allow the JICA team to come in within a short time to talk about the patient safety project, which we are all expecting and we are looking forward to have in our sector to make a change in the culture and practice for patient safety. The JICA representative, please.
Thank you, Chairman, for introducing JICA. Honorable Minister, the Director General, Ministry of Health staff, and all the distinguished guests. Good morning to you all, and it is great honor for me to be able to be here and to address the remarks this morning. Sorry, no, in the afternoon. So first, I'd like to express our sincere gratitude to your tremendous effort in handling the situation of this COVID-19 situation, pandemic. With the leadership of Ministry of Health, the mass vaccination campaign is now ongoing on the ground, and we are now able to see the number of doses and people being vaccinated increasing. So today, I'm very pleased to be here with all of you at the launch of JICA's new project called the Project on Patient Safety Establishment through 5S Kaizen TQM. As you are all aware, JICA has supported Ministry of Health through several schemes, such as technical cooperation and grant aid project for the past 20 years. So the 5S CQI TQM project that was terminated this July had been implemented since 2011 through 2 phases. Because of this project, some of the regional referral hospitals have become center of excellence to share their knowledge and experience to other hospitals and health facilities. Furthermore, the rate of the medical equipment that operate on the good condition has increased from 65% to 84% in average in the regional referral hospital. So the 5S activities have become very basic activities in the everyday management of the hospital especially the regional referral hospitals in Uganda now, by starting with small Kaizen and making steps towards total quality management. At the end of our previous 5 years CQI TQM project, JICA supported the purchase of calibration equipment worth about $450,000 to the central workshop and regional workshop of the Ministry of Health. Keeping good condition of medical equipment is critical to provide good health service, which will directly connect to the patient safety. For JICA, Uganda is the first country to focus on the patient safety on the African continent as a project. So it is our pleasure to cultivate the patient safety culture through 5 years TQM, 5 years CQI TQM. In other words, the Uganda will be a good model of patient safety with our colleague at Ministry of Health. On our part as a JICA, we are working together with all of our stakeholders. Thank you for listening.
Thank you very much, Martin and the JICA senior representative. You are done? Okay. Honorable Minister, at this juncture, allow me to invite Catherine to read the statement of the Mission Director, USAID. And I'm told she's online. Catherine, you have the floor.
Can you hear me okay first? Are you able to hear me now?
We are getting you clear, Catherine.
Thank you. So first, with appreciation to my previous colleagues who were just speaking on from JICA and even Martin, really appreciate these comments and the shared slides with all of us. I'd first also would like to thank the Minister of Health for her presence and her support with the USAID and with the US government. It's really my pleasure to be here to celebrate the achievements of quality healthcare services in Uganda, even as we adapt to the COVID-19 challenges. So I really want to particularly thank the Honorable Minister of Health and your entire team for your resilience in fighting the COVID-19 pandemic. I also want to thank the entire community of frontline health workers who continue to deliver healthcare services to patients despite the challenges and circumstances with COVID-19. The US government works in partnership with the Ministry of Health to overcome the obstacles to providing quality healthcare for all Ugandans. For example, we develop community service delivery models that bring healthcare closer to people. Additionally, we helped expand virtual platforms which allow healthcare workers to maintain contact with clients during the lockdown and other restrictions. The US government embraces innovations that demonstrate results at the national scale, such as quality improvement structures to enhance patient safety, quality, and efficiency of care. Evidence from these innovations and other large-scale quality improvement efforts shows that quality healthcare can be achieved with the current health system with simple, affordable, and scalable tools to guarantee quality services for all Ugandans. We are encouraged by the significant improvement in health indicators between August of 2020 and this year of September 2021, despite the potential negative effects of the pandemic. Specifically, there was an improved antiretroviral therapy retention for children and adolescents living with HIV from 58% to 75% over a one-year period. Viral load testing coverage moved from 71% to over 90%, and the viral load suppression rate went from 72% to 87% over a one-year period. More improvements were achieved in the number of TB patients identified, which increased from 72% in fiscal year 2019-20 to 88% in this fiscal year of 20 to 21. At the same time, TB treatment rates increased from 79 to 85%. That's quite an accomplishment. While this is commendable, there's still challenges and gaps in ensuring the quality of care. The annual health sector performance report for fiscal year 2019 to 20 showed only 59% of babies are delivered at health facilities, and there has been no increase in the percentage of women receiving a fourth antenatal care visit. The availability of basic hand hygiene supplies and equipment in health facilities stands at 86.5%, while only 44% of facilities practice safe management and disposal of infectious medical waste. Additionally, the Ministry of Health Performance Review Report for January to June 2021 shows that client satisfaction is still low, which is at 31% against a target of 79%. The report also registers an 8% decline in reporting the numbers of mothers who died between fiscal year 2019 and 2020. This can be due to underreporting, which is also a quality improvement issue that needs to be addressed. To overcome these challenges, practitioners must continue to adopt and apply best practices such as psychosocial support and taking services closer to patients to achieve better health outcomes at scale. The Ministry of Health needs to enhance efforts to keep frontline health workers safe, increase the demand for health services, and sustain client-level outcomes by engaging and empowering communities and households to stay healthy. The newer threats of COVID-19 and its related challenges are perhaps bigger and more complex than other infectious diseases that dominated the health agenda in the past. But this means that the government of Uganda and partners need to think innovatively about quality improvement across healthcare systems, whether in daily problem solving or in large time-limited projects. To cascade sustain gains already made, the Ugandan health systems need to continue building skills and using learning mechanisms such as this conference. To build the capacity of health systems and overcome some of these challenges requires, above all, greater financial commitment from the Ugandan government. Every year, the American people invest more than $500 million to support Uganda's health sector. This is almost on par with the Ugandan government's annual health budget, which ranged between $500 to $700 million in the last several years, except last year did increase to $900 million due to COVID-19. We encourage the government of Uganda to continue to increase its health budget and look for complementary financing options such as health insurance schemes to sustain the current gains. The Quality Improvement Conference provides an opportunity to learn what has worked well and celebrate it, while it's also reflecting what needs to be done to improve the resilience and quality of health systems. I look forward to learning more from your stories, innovations, and commitments today. On behalf of the U.S. government, I thank the Ministry of Health and the other organizers for this important annual event. Our U.S. government is committed to working with all stakeholders to improve the quality of healthcare in Uganda. I wish you a productive and...
Thank you very much, Catherine. Madam Minister, Catherine Owens is the HIV/AIDS team leader at USAID. Maybe also let me take this opportunity to introduce Fukuhara Ichiro, the one who co-presented with Martin, is the new senior representative for JICA in Uganda. Okay. So at this juncture, Honorable Minister, allow me to invite Dr. Bayo Fatumbi to make a statement on behalf of WHO. Bayo is a household name in the Ministry of Health. I'm sure many of us know him. You have the floor, sir.
They also say Bayo from Arua. That's my name. The Honorable Minister, the Permanent Secretary here with us in the spirit, the Director General, Dr. Henry Wembesa, other development partners here present, the directors, the commissioners, the assistant commissioners, our gatekeepers in the field, the DHOs, the health managers, and all other frontline health workers. Ladies and gentlemen, I bring the apologies of WR, whom you know where he is currently, an essential duty travel out of the country. I wouldn't want to miss this type of meeting. It is also a pleasure to congratulate the Ministry of Health and all partners for the successful JRM that happened last week. And this is one of the measures to improve quality of healthcare delivery in Uganda. As you all know, when we say good health and well-being of all, as is written in SDG 3, the good there talks about quality. So this meeting is very apt, coming at this time as we come out of the burden imposed on us by COVID-19. Let me also put it on record that Uganda is also one of the first countries that quickly instituted the pillar, the 8th pillar, for addressing and responding to health emergencies, the continuity of essential health services. And I want to appreciate you again for using the word in your directive, dual response. This is very key. We were able, despite the fear that was brought to us by COVID-19 early in 2020, we were able to still continue to maintain essential services because of your leadership. We appreciate this a lot, not only for Uganda, but also for the countries that are in the region. We always talk about Uganda as a gatekeeper for the East African community. It is very important that even before the COVID-19, especially in many other countries, the epidemics that we have observed had tested the health system, tested our strength, our resilience, and this Uganda has been able to do very well. However, there will be room for improvement, and that is why we are having several measures of measuring performance, monitoring, tracking, and using the recommendations for action. It is very important that we also know that the 6 pillars of health system strengthening for a resilient health system had learned a lot from the COVID-19 pandemic and the response that came. And I want to urge all of us that we remind ourselves of those pillars, not only at the national level, but also for all the frontline health workers that are here. It was a delight, Honorable Minister, to hear some of our colleagues in the field talk about motivation. This is under the issues of health workforce, quality health workforce. In the area of leadership and governance, you have been on top of it. Again, there is also room for improvement. The aspect of health financing, you've done so well to increase the budgetary allocation to health, but we need, especially again during the COVID-19, the government put in a lot to get vaccines. We need to do more and sustain the efforts that we have gathered during the COVID-19 response. Health information is very important, and I'm happy to say that the database will also assist us in this area. We need to cascade it, take it down, so that at the click of a button, the DHO can effectively interpret its own data and move ahead with some appropriate actions. Access is very important. That is what we are trying to foster during this meeting. And we urge you to be very frank, just like we had during the post-discussion of the first discussion that we had, keynote address. Please come up with the issues. We are lucky in Uganda, probably unlike some other countries where you may not be able to say it the way it is, but we have a leader who is available to hear you out, like the DG had demonstrated, and then brings some solutions. So we request that you make this meeting as practical as possible. It is very important that we put machinery in place because the risk factors for health status, they are not limited to health sector. So we urge you to look at approach from the whole of government, the ministries, the departments, and the agencies. And moving further, let's engage the whole of society approach. I'm happy the private sector is here. We have the CSOs representing the communities. So all of government approach to improving this quality will be very key. It's also very important that we engage the whole of the society. We want to thank you very much that we must put machinery in place to monitor the implementation of the decisions we'll be making from this meeting. This is very important so that we can sustain, check ourselves and sustain the good work that is already ongoing. On the part of WHO, we continue to commit, just like we have done in the past. We will improve on our commitment to support the implementation of the decisions, the monitoring of this quality that we so much going to have, including through the GRM and other mechanisms at the subnational level that guarantees continuous monitoring and evaluation. I wish you great success during this deliberation and the importance of looking ahead at the ultimate result of improved quality of life of the 45 million, more or less, Ugandans. I thank you very much.
Thank you very much, Dr. Bayo, for that statement on behalf of WHO. Honorable Minister, apologies from the PS. The Permanent Secretary was supposed to invite you to make your statement and to launch the important documents. She has assured us that she will join this meeting tomorrow. She will read her statement tomorrow. So I want to grab that opportunity in her absence to make a few comments. I don't have her speech because we've reserved it for her still to make it tomorrow, but I'll just make a few comments and invite you to address the congregation. Thank you. Honorable Minister, the Director of Health Services, Governance and Regulation, and all senior colleagues from Ministry of Health, the WHO country representative, the mission director, USAID, all our health development partners and implementing partners present here and online, all colleagues present physically and those online, protocol observed. Honorable Minister, first of all, I really want to thank you so much for coming to grace this very important occasion. We all know how busy you are, especially at this time. I know you are even supposed to share another meeting at midday, but I know you, because of the importance of this meeting, you are trying to work it out and see how you combine the two. I also want to thank all the participants who are here, physically and online. We have as I said, we have about 200 here present today. Last year, because of COVID, we had 50. I recall it was in Mestil Hotel, and we could only afford to take in 50. As I said already, this is our annual meeting, which we hold every year. This is the 8th, where we come to share experiences on a number of quality improvement initiatives that have been taken place during the year. We learn from best practices. We learn from what has been done, the lessons learned, the challenges and the way forward. And there are quite a number of presentations that will be made, especially in the breakup sessions. And here I want to thank the scientific committee, which looked at the papers submitted and selected the presentations that we are going to have, Honorable Minister. And this will go on from today up to Friday, this being a 3-day session. As you already know, the theme is fostering delivery of quality of health care in the context of COVID-19. I'm sure everybody in this hall knows how much COVID has affected us in this country, not only the economy, but also the health services. Since last year, we sometimes say March, but really the situation started as early as January, because I remember by January last year, we were already in the planning and preparation phase for the COVID, starting with the airport testing and screening all passengers who were coming in. Sorry. So literally we are counting from January last year. We can confidently say that this is coming almost to 2 years. And as you know, Honorable Minister, your staff are really getting tired because the challenge, we always deal with epidemics, but most of the epidemics we know, we really handle them 3 months and you are done with the epidemic and you move on, maximum 4 to 6. But this one has gone on for 2 years, so certainly it has implications on the delivery of quality healthcare services. But in a special way, I want to thank all our health workers who, despite the COVID, have managed to, like Dr. Bayo said, I tested yesterday, so I'm negative. Don't get worried about my sore throat. So we established the continuity of essential services pillar. So I really want to thank all our health workers who have helped to make sure that despite the COVID, the essential services continued. And as you know from our annual performance report, we really managed to keep all services okay. And most of our indicators improved. A few stagnated, but majority improved, and despite the COVID situation. And I wish to encourage all our colleagues to access our annual performance report and see our performance in the last financial year. It should be online, and if it's not yet there, I'm going to encourage our team to put it online for everybody to have a quick run through. Since we are talking about COVID, let me quickly run through the information which you all know. To date, we have cumulative cases of 127,267 out of about 2 million tests done. With this, about 3,250, actually 3,250, not about, and about recoveries of 97,300. We have so far vaccinated about 6.2 million doses of vaccine, and of those, about 5 million have received the first dose, and about 1.2 have received the second dose. If we consider that we have vaccinated some people with Johnson & Johnson, which is a single dose, and so far we have used about 1.4 million of Johnson & Johnson, and then we have 1.1 million of those who have taken the second dose, we can say that about 2.5 million of our population is fully vaccinated as of now, but the actual details can be provided in the program, but roughly about 2.5 million. Honorable Minister, we estimated about 150 health workers to have received COVID vaccine. I'm proud to say about 95% of our health workers have received vaccination. That's 142,000. Recently, we are saying that health workers who are not vaccinated will not be allowed to come back and work. Not that we are sacking them, but we are saying, since we are working in a dangerous environment in the health sector, that if you are not vaccinated, maybe it is better you vaccinate first, then you come. If you are not vaccinated, then you wait. But then that means that if you are going to wait for 2 or 3 weeks without coming, then that means we will sometimes wonder whether you are still our staff. But if we can say 142 out of 150 are vaccinated, of course 150 is almost, it's an estimate. We could as well assume that we may not have very many health workers who are not vaccinated. But if they are there, please, we still encourage you to complete that vaccination. Those 8,000, if you are in government health facilities, it may be difficult for you to come and work. Madam Minister, we are also, we've received reports that over 350 teachers have been vaccinated. Out of the 550, 380 actually, out of the 550,000. So I think teachers are ready to start teaching, and that is a good sign. Because also, the 550 actually is an estimate. You know, it's easy to get the numbers, especially in the public sector, but when we estimate also for the private sector, that's why we are saying some of those numbers are estimates. Of course, we get from the registrars the numbers, but we can confidently say that I think most of our health workers are vaccinated. I can also say that by the end of this year, by 31st December, we expect to have received adequate vaccines to cover 22 million of our population, considering that we're expecting about 10 million doses of Johnson & Johnson. That means 10 million people. That 10 million doses is coming in by December, and we have already received 1.4 of Johnson & Johnson. That's almost 11.4. And if you combine with all the Pfizer, the AstraZeneca, the Moderna, then we are really nearly there. The only point which I want to request, Honorable Minister, for you to emphasize is to call everybody to come and get vaccinated. Once again, I want to thank our health workers for the great work done amidst the COVID situation challenges, and also to say that we appreciate that almost all our health workers who worked in CTUs did not get infected, which shows that we took seriously the infection prevention and the control measures. The training was good, the PPE availability was adequate, and we appreciate that, because this is it's not a mean thing, because we also know even in the first world, there were a number of health workers who were infected in the COVID treatment units, but I think we did very well. I had some people trying to clap. I thought they would actually clap. Thank you very much. So, all I can emphasize as the technical head of the health workers is let's please emphasize on infection prevention and control to protect ourselves. Much as we are vaccinated, we still have to emphasize to protect ourselves, because we are the front line, and in that unit where you are, you may be in the OPD, you may not be in the COVID treatment unit, you may be in a health center in an outpatient, but you may be dealing with a patient who is coming in with just a fever. You think it's malaria, but you may be dealing with the COVID patients. So please, let's emphasize our IPC, infection prevention and control, and let's take serious precautions to protect ourselves. In conclusion, Honorable Minister, I want to thank SCAP of the department and the directorate for spearheading the work and the preparations for this meeting. I want to thank them in a special way for also spearheading the documents that we are going to launch today. For example, the National Quality Improvement Framework and Strategic Plan that is ready for launch today. And therefore, I also want to thank the partners who have worked very closely with us to develop that document. I also want to thank the department and directorate, together with colleagues in the Ministry of Health, for the preparation of the National Quality Improvement Database that you are also going to launch today. This database is going to help us to monitor our performance, especially to monitor quality improvement and performance improvement in the health sector. I want to congratulate and thank JICA for supporting us and launching with the Patient Safety Establishment Project that we are going to launch today. This is a 5-year project, and we thank JICA for the continued support among all other projects that we have received with support from the government of Japan. Honorable Minister, as I said, my role was just to invite you. Allow me now to introduce you and invite you to come and address the delegation. Ladies and gentlemen, join me to welcome Honorable Jane Ruth Acheng Ochero. I was reading the new guidelines. They say if you are addressing a honorable and doctor, you don't put there doctor, you say honorable. She's a Minister of Health. She's a senior consultant pediatrician. She's a public health specialist. She's a woman MP for Lira City. She's a wife to a QI expert who will be introduced later when conditions allow, and she's also a mother. Please join me to welcome our minister. And I'll make sure I'm not responsible for any of her problems.
Thank you very much, DG. And thank you for killing your corona very well. I appreciate. The Director General Health Services, the World Health Organization representative, representatives from PEPFAR, USAID, CDC, and the UN agencies, the directors from Ministry of Health, heads of departments and institutions present, representatives from the academia, registrars of health professional councils, district health officers, other officials from ministries, departments, and agencies, our implementing partners, civil society organizations, the staff from the Ministry of Health, and all health workers, invited guests, ladies and gentlemen. First, I apologize that we are opening rather late. I know you're all tired. It has been a long morning. I do apologize for the late opening. Allow me to welcome all of you to the 8th National Health Sector Quality Improvement Conference 2021, and to thank the organizers for making sure that we hold it in spite of the pandemic. And in a special way, allow me to welcome delegates from outside Uganda who are joining the conference via the Zoom link, and also those of you who are physically present here. We don't take your presence for granted. Thank you very much. I wish to recognize with appreciation the various frontline health service providers from across the country that are involved in implementation of the different quality improvement interventions in the health sector. And for you to choose to come, especially those of you who could have been on industrial action, is that what you call it, and are here. Thank you for putting aside the industrial action and coming to participate. This conference gives all of us an opportunity to reflect on our achievements in quality improvement in the sector. It is also a platform for us to share experiences, lessons learned, challenges that we have gone through, especially in the last 2 years, and the opportunities that have been presented to us in implementation of QI interventions in healthcare, both locally and internationally. I am therefore excited to see the high level of participation and also your commitment towards improving the quality of healthcare services in the country.
The theme of this year's conference, which you're all familiar with, fostering delivery of quality health care in the context of COVID-19, is not only a timely one, but is also a good one. We all know COVID-19 pandemic has been a serious constraint towards offering quality health services in Uganda and beyond. And we all know the challenges that we have gone through in these last 2 years. First, I would like to appreciate that a lot has been done, as was clearly highlighted by the Director General, that in spite of the pandemic, we have made good strides. And I think you all deserve a clap for yourselves. In spite of the pandemic and the good strides, we also thought about our rights. So many of you have also had activities of industrial actions. Others were for lunch allowance. Others are for salary enhancements. Others are for just being tired. I think some people are about to go on industrial strike for being tired. That would be a nice one, and I would gladly participate in that one. But I'm not going to be the initiator. So the one who initiates you, contact many of us. But that is not to say we should sit down. The health sector needs us now more than ever. As His Excellency plans to open the economy, we need to engage another gear and work even harder to make sure that we fill in the gaps for what has been missing in the last 2 years. We want to remember the families of the colleagues we lost during this COVID-19 pandemic that are no longer with us. The priceless contribution they made to serve this country will always be in our hearts and minds. And I would like, therefore, to request all of us to observe a moment of silence in honor of their memories. So let's stand up and honor them. May their souls rest in eternal peace. Please take your seats. I think I would also like to remember those who contracted COVID. Usually we forget them. There are many people amongst us here who contracted COVID, who have stories to tell. Some are good stories, some are difficult stories. We also want to remember you and pray that even as we move along, remember to get vaccinated and keep your mask on, because we don't want you to become another of those statistics that the Director General was reading. Don't become part of his annual sector report that he will read next year, because next year the statistics will be even much bigger. I pledge not to be part of your statistics. I understand as a country, we have revised the National Quality Improvement Framework and Strategic Plan, which Mr. Sendiona talked about. I would like to congratulate the team that has put together the different ideas in this third edition for our implementation to improve quality services in the coming 5 years. I call upon each one of you to support this effort for a well-coordinated and harmonized approach towards implementing quality improvement interventions in Uganda. We all have the responsibility to implement quality improvement in an institutional-based manner and to avoid duplication and unnecessary wastage of resources. A few days ago, we held the 27th Joint Review Mission for this financial year 2020-2021. And as you heard from the DG, we were able to register improvement in some of the key performance indicators. There was positive change observed in fresh stillbirth rate, which improved from 9 to 7.1 per thousand. Minimal drop, but noticeable and remarkable. We also had a drop in maternal death review from 72% to 76%. The proportion of HIV-exposed infants with the first DNA PCR test within 2 months of age increased from 71%, from 56% to 71%. The progress made in the different areas of performance in the health sector can be attributed to efforts made in implementing quality improvement targets and programs that are critical in healthcare and support. It is my wish that this conference shall bring out more factors that facilitated the improvement that was achieved, and also suggest ways of scaling up best practice to different parts of the country using integrated and sustainable approach. One of the areas that we really need to critically work on is our presence on duty, and also in a timely manner, but also our output, which has indeed gone down. On the other hand, we need to work together to address gaps that are still hindering success in other critical areas of service delivery. We take note that maternal mortality has stagnated, and unfortunately, teenage pregnancies, early child marriages, defilements have all gone very high. Recently in Cabinet, we had opportunity to look at statistics of teenage pregnancies. The numbers are quite high, and I don't want to imagine what will start happening from now up to next year when all these adolescents go to hospital to give birth. We know the challenges they will go through. There will be many maternal mortalities, many, that will add onto our statistics. There will be many infant mortalities that will add to our statistics. The danger we face is losing the gains that we have made over the years. But there is an answer to all this, and that is if we put in effort, each one of us, looking at these adolescents as human beings who need attention and giving them the critical care that they deserve so that we minimize the mortalities. Of course, I know many of us will say that part of the solution lies with them. They need to get to the facilities early. Again, still the onus is on us to ensure that our community health systems work and encourage them to go to seek treatment as soon as they need it. There are other areas that we'll have to pay attention to, and that is anemia in pregnancy, and also ensuring that the mothers receive their folate supplementation that is still low. We also have to pay attention to our immunization rates. Indeed, during this pandemic, all of you have worked very hard to ensure that we maintain the high immunization coverage, although we had a slight drop in the coverage of measles from 88 to 86%. There is a lot that can be done. We only need to remain committed, and we can do it. So your deliberations here should also entail a recommitment in spite of the challenges that we have gone through to see our health sector move forward. Yesterday we had a meeting with His Excellency the President regarding the industrial strike. I am sure that those who were there heard what he said. I am only telling you as a secret, but I heard him very clearly when he said it is time to give more money to the health sector. I even said the amount. DG, you heard? And he made a remark. He said, many people don't understand that when you invest in the health sector, it pays off in the long run. And he is committed to investing more in the health sector beginning the next financial year. So it is a secret, but let's watch the space. I'm sure that secret is going to come alive as we move forward. So as we continue with our discussions, I would like you to observe the following. Improving quality of care as a means to reduce ill health and preventable deaths of mothers within our institutions and communities, but also emphasizing on prevention. There is a lot to do to address the 75% disease burden that is in our communities. As government works hard towards addressing poverty through the parish model and many other models, let us take advantage of that situation and also improve on our health services in the communities, using the communities themselves to realize that they themselves can actually improve their health and prevent a lot of illnesses that are preventable, that you are aware about, including malaria. 2, improving quality of care as a means to reduce neonatal mortality within our institutions for both public or private service providers. Improvement in client satisfaction within our services. I do hope that we are not going to hear again the situation we had at the height of the second wave when everybody was complaining about prices in the private health facilities. The good news is that the courts of law gave us authority to control and regulate the prices. I know the private sector is not happy with us. As soon as we append our signature, whoever is not happy, you bear with us. The courts of law gave us authority. So if you're not happy, then you go to the public health facility, and we shall welcome you with 2 hands. 4, reduction in absenteeism of health workers, more especially the medical doctors. The medical doctors, yes, you need more money, but you need to be more available. You need more money, but you need to be more available. And not only being available, but actually doing the work. Because being available might mean coming to the facility, signing in, showing your face. We want you actually to attend to the patients and give them quality time. And lastly, offering health care in an environment which is safe to both the client and the health workers. Colleagues, it is a very glaring observation that the quality of our healthcare services has been affected by COVID pandemic. and it has led to disruption of essential health services, as well as in the supply chain of essential medicines and other supplies. And this poses a serious threat to the safety of the healthcare providers. But I would like to encourage you that many of those issues that we faced have been addressed. The issues of oxygen, come December, we hope so, will be history. Challenges that we met with some of the intensive care units and high dependency units have been addressed, and we are looking forward to many more human resources being recruited in the entire health sector structure up to health center 3s. So we do hope that the system will be strengthened. So those of you who are jobless, you will have a job come next financial year, if you are willing. If you are willing to go to a sub-county. I know some people will say, for me, I can't work in a sub-county. But one of these days, I think there is more fresh air down there in the sub-counties, and maybe less terrorist attacks. I don't know. I've been informed that for the next 5 years, we shall pay attention to patient safety through support from the Japanese Agency for International Development, JICA. I would like to welcome back JICA to Uganda and thank them for the continued support to the health sector. Let's appreciate them. I also wish to urge each one of us to support and participate in efforts to strengthen and improve patient safety in Uganda. As I conclude, allow me to appreciate the Directorate of Governance and Regulation in my ministry and the able and focused leadership and guidance of the entire team, ranging from the Permanent Secretary, the Director General, and the Director Governance for consistently organizing this conference and bringing us up to date with issues of quality improvement. Allow me also to appreciate the following partners that have supported this year's National Quality Improvement Conference: the World Health Organization Country Office, the Japan International Cooperation Agency, UNICEF and UNFPA, USAID and its affiliated partners, CDC and affiliated partners, the Clinton Health Access Initiative, and Makerere University School of Public Health Monitoring, Evaluation, and Technical Support, METS. Thank you very much for enabling us to have this conference this year. Like I said before, I was informed that there are a number of documents that we shall be launching, and so I would like to invite those who are preparing the documents for launch to get prepared so that we can launch the 3 documents: the National Quality Improvement Framework and Strategic Plan 2021-2025, the Patient Safety Project, and the Quality Improvement Database. As I conclude, allow me to appreciate all of you for attending this conference and for your commitment in ensuring that we improve the quality of healthcare services in Uganda. And in a special way, to appreciate all our partners who have continued to give us unwavering support, both technically and financially. Lastly, I would like to know, amongst us in the room here, if you're not vaccinated, just stand up. I have a gift for you. You see, part of quality improvement is being sincere. Because if you're not sincere, then you're not committed to quality improvement. So it is just nice to be very sincere to yourself and stand up so that I can give you your gift, and then you can get vaccinated. So those who are not vaccinated, God is watching. And is pointing hands to those who are not vaccinated. So are we all saying, all of us here in this room are vaccinated? So later on, as we are going to exit, since we are all vaccinated, I'm going to ask security to round up the place and we all show our vaccination cards. So those who have a card will go for lunch. Those who don't have a card will stay behind, and I give you your gift of a beautiful flower. Is that acceptable? Very good. So thank you very much. I wish you all very nice deliberations. And as I go to launch the documents, allow me to declare this Quality Improvement Conference officially open for God and my country.
Another big clap for the Minister. Honorable Minister, the Director will take us through the launching ceremony.
Complete it from there.
Okay. Thank you. Thank you, God.
Thank you very much, Honorable Minister, for blessing the 8th QI conference and giving us official permission to proceed with this wonderful conference. So we have 3 launches to make, Honorable Minister, and we shall do them in a very short time so that we can have lunch together with you, and then we get back to business in the afternoon. Martin and the committee, I hope that you are ready with the symbols for the launch. As I invite Honorable Minister to once again come down with the Director General. We have the markers ready. Invite WHO, country representative, JICA team, because we're going to launch the project. Please come forward. USAID, chiefs of parties present. We're trying to limit numbers, but we can accommodate a few. Come down and we launch this. The academia, the partners, please come forward. School of Public Health, METS, please come. Can we have the books ready? If you already have your copy of the book, please come with your book, the QI framework. Alex, Martin, we don't see the books here. Copy. copies. We need the copies here for the launch. In the bags. Okay, Honorable Minister, you have your microphone, I think. No, there's one for special one there. Yeah, that ours are in the bags. We had the bag. No bag. Okay, so we shall start with the National Quality Improvement Framework and Strategic Plan, the book. Beautiful color, beautiful steps that we have taken in the quality improvement journey, Honorable Minister. So this is yet another one for 5 years, beginning this year to the end of 2025.
Thank you very much. I hope I can be heard.
Yes.
I know there are some people in the audience who have the book. I have also been told that the books were distributed. Please take time and read it. This book was developed to guide implementation of all quality improvement interventions in the country. It is intended to harmonize approach towards implementing quality improvement to facilitate integration and sustainability of the introduced new changes. And we appreciate the stakeholders that have been involved in the development of the framework. It is now up to each and every one of us to use this policy document effectively. So it is now my honor and pleasure, and I will share mine with the DG. Why don't you hide it here? To declare the National Quality Improvement Framework and Strategic Plan 2021-2025 officially launched for God and my country.
Thank you very much, Honorable Minister. So now we have an active improvement framework and strategic plan in place to guide the work in the sector. Thank you. So we do this signing now. We launch all of them, then we sign. Thank you for the guidance. Okay, so now we launch the QI database, and then thirdly, we shall launch the new project to drive all these efforts. It's electronic?
Oh, so we shall sign it?
Yes.
So the quality improvement database shall be used to keep tracking progress made in implementation of the 5S continuous quality improvement work in the country. It is intended to strengthen monitoring and evaluation of implementation of the 5S continuous quality improvement interventions in the health sector. It is expected to facilitate improved use of data at all levels of health service delivery for more informed decision-making in the health sector. It is now my honor and pleasure to officially launch the National Quality Improvement Database 2021 for use in the health sector, for God and my country.
Thank you very much, Honorable Minister, for launching the QI database. Then lastly, Honorable Minister, we welcome you to launch the new project funded by JICA, Government of Japan. They gave us already a brief about the new project. So we believe the resources and the expertise that is coming with this new project will help the sector to drive the quality improvement agenda forward. You have the citation.
Thank you, Director. I'm glad that The JICA head who will be running this project with us is right next to me. I wonder whether he has a Ugandan name. Not yet. So please don't name him COVID. Or don't name him AstraZeneca. You need to look for a good name. The Patient Safety Project aims to establish safety culture through 5S continuous quality improvement, total quality management approach. The project sites shall be the 16 regional referral hospitals. That is Arua, Entebbe, Fort Portal, Gulu, Hoima, Jinja, Kabale, Kayunga, Lira, Masaka, Mbale, Mbarara, Moroto, Mubende, Soroti, and Yumbe. There will be one national referral hospital, that is the China-Uganda Friendship Hospital, Naguru, and Tororo General Hospital. The Ministry of Health appreciates the support the government receives from the government of Japan through JICA. It is now my pleasure to officially launch the Patient Safety Establishment through the 5S Kaizen Total Quality Management Project 2021-2026 for God and my country.
Thank you very much. Now we can sign. We have several markers here for members. Honorable Minister, your marker will be brought to you. We have sanitizers also. Make sure when you're sharing the markers, you sanitize in between. Yes. Give DG. Director General, there's a green marker there. If you want green or red, it is your choice. Today's 24th. Today is 24th of November. Thank you very much. Honorable Minister has signed, symbolizing the launch of the QI framework and strategic plan. DG has already signed. He needs the date. And the Honorable Minister is signing on the new project supported by JICA. After the signing, Honorable Minister, we request that we take a group photograph right at this spot. But we shall be careful not to crowd, and we keep our masks on. Okay, just a moment. We need a picture with those as DG finishes. Then we shall move in front of the high table here for the photograph. I will say no problem. Emma, come and do your job. I'm going to sign. I hand over to Emma. Now we have photograph and then I think lunch.
Thank you very much, Director. I think in one of your careers you should have done our role because you have a great voice. So then we can now have a group photo. They want it just below the stage. They want it here. Thank you. I think we can have now a group photo in front of the yes, in front of the stage. Yeah, down. No vision. I hope you've gotten an interactive picture. Oh, yeah. Make sure you smile. We don't want gloomy pictures. Okay, cheers. Thank you very much. Allow me to appreciate the chief guest, the Minister of Health, who has just concluded a launch of 3 vital documents and also a new project, Patient Safety Establishment Project. Yes, this brings an end to our first part of today's conference. We are going to have a lunch break, and thereafter the lunch break, we shall have plenary, the various breakaway sessions, and we appreciate the Honorable Minister for having spared time for us. The ushers will provide the coupons on your way out, right here in the middle, and the other exits. Honorable Minister, thank you very much for being part of us today.
And ladies and gentlemen, during our breakup sessions, we shall have these sessions in 3 halls. We shall have one here in this hall, chaired by Dr. Alan Muruta. Then we shall have another breakup session in Mahogany Hall, that is right below us. That will be chaired by Dr. Julius Bamwine, DHO Ivanda. Then we shall have another breakup session in Acacia Hall. It's right next after Mahogany Hall, chaired by Dr. Juliet Nabanja. So feel free to choose any of the sessions, and we would love your full participation. That's immediately after the lunch break. So after the lunch break, please choose one of the 3 breakup sessions and join the discussion in those 3 halls. So ladies and gentlemen, let's break off for lunch. Bon appetit. We are having a 1-hour lunch break. So it is yes. So at exactly 2, let us be around in our specific halls for the breakup sessions. As I said before, we are all not converging back here, but we are going to our respective breakup sessions. We have 3 of them, one in this hall. That's the Speak Ballroom, chaired by Dr. Alan Muruta. That's governance is the theme. We have another in Mahogany Hall, just below us, to be chaired by Dr. Julius Bamwinde, DHO Ivanda. The theme is health infrastructure. Then we shall have a 3rd breakup session in Acacia Hall, just next to Mahogany, chaired by Dr. Juliet Nabanja. The theme is special groups and health information. So feel free to choose any of the sessions, and we urge for full participation. Thank you. We are expected in our session, in our rooms at exactly 2. The breakup sessions will be open. So those also online, please choose wherever you want to fall. Those online, breakup sessions will be open. So you choose wherever you want to fall. Thank you very much.
Yes, 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 towards the end. Okay. So Elizabeth, you're also on the program? On his behalf? Okay, so there is also one by Dr. Martin Sendiona, and the last one will be by Joy Batusa. So we have 5 presentations, but I can see all of them were allocated 15 minutes. But I want to agree with you, or you to guide me, whether we should use all the 15 minutes. Because now we are in some kind of crash program. We lost time in the morning session, so we have to make sure that we cover today's program in the remaining time. So I want to suggest that each presentation will take not more than 10 minutes, and if you can make it shorter, maybe 7 minutes. Is that okay? So, Dr. Dennis, please come and, as he comes, looking at the program, the discussion is coming at the end, and therefore I expect that we shall have the presentations first, all of them, and then we have discussions at the end. That's better? Please write down your questions and comments, and then we shall have a 20 minutes discussion. So Dr. Dennis is going to take us through a presentation on leading by example, surged COVID-19 vaccination uptake in Lamu district, northern Uganda. Where is Dr. Dennis? Yes, you ready? Please start. Come again? Oh, the technology is...
Yes, we submitted to the program controllers. They should just project it up.
So please, whoever is responsible for projecting, let him project. We are ready to start. Dr. Mumpe, what is happening? So you'll be presenting from there? Okay.
They are going to be using the podium microphone. The microphone is already there.
They are long.
Yes. They are going to project.
Okay. Nyabo, I'm busy. I sent you WhatsApp. Did you read it?
So good afternoon, everybody. My name is Umoya Dennis Ochula. I work with Lamu District Local Government as the Acting District Health Officer. What I'm going to share with you this afternoon is a snapshot of what we did as a team in Lamu as far as scaling up COVID-19 vaccine uptake is concerned. You will agree with me that in March, when this vaccine was introduced into the country, especially for the first categories, people who are seen to be more at risk, the health workers, teachers, armed forces, elderly, people with comorbidity. The message was received with mixed reaction. largely negative one. We started off our vaccination exercise. Next slide, please. We started off our vaccination exercise on the 15th of March with a launch, and these are some of the reasons why we would like to share this. Next slide. Okay, here, thank you. Okay, we saw that we needed to mobilize our people in order to improve on the uptake. And what we did was to organize for 2 sessions of launch. The first one was targeting the health workers, and then the second one came about 2 weeks later after realizing that the uptake was not good with the health workers. There you can see it was on the 15th when the RDC, the LC5, the COW, the DHO was meeting members of the DHT, Health Unit Management Committee, health workers, and the media during the launch. The intention of inviting the media and other community members was deliberately to let people know that the health workers were taking this vaccine. There was something good coming to save our lives. And the DHO received this vaccine, the first shot on that day, 15th, together with 19 other members of the DHT. We then led a team to do a micro-planning. By that time, we had some plan, but it was not good enough. 2 weeks later, like I indicated, we saw that the uptake for the health workers were not good. We said, fine, let's have another launch. And this time it should be conducted in 5 different locations within the district, targeting the teachers and others. You can see people who are gathered, seated during the launch. And in each of the 5 stations, we made sure that the district leadership, the leaders, received their first dose in those places. The RDC went to one place, the COW went to another, the DHO, the District Inspector of Schools, and the District Internal Security Officer. All these received their vaccination in the different locations. And in a way, it gave a very, very positive message to the people that it is truly something good. And the media too was invited. Some of them also received their vaccination. And in the evening, we could hear on the local radio stations, they talk about the vaccine being in the district and how the district leaders were also willing to take the vaccine. So our intention was to quickly move ahead and reduce any negative information that would arise. So there you can see my COW speaking during the launch, and down the DHO receiving his vaccine. And then there you can see the Inspector of Schools receiving his vaccine during the launch. And 1 month later, we tasked now the LC3 chairpersons, because we were monitoring. Every LC3 chairperson was supposed to come forward and also get vaccinated, for those who never had a chance during the launch. And we gave out vaccination targets to each one of them, because we realized by that time we had already won them on our side. None of them was talking negatively about the vaccine. So we had a target given now to the LC3 chairpersons, aware that anything to do with numbers, it is the political leaders that can drive. For us, the technical people, we deal more with quality. So the issue of numbers, we put it on their side, quality on our side. But we were working very, very closely with them to ensure that there was no deviation to the standard talking points provided by ministry. And what were the results? there was improved vaccination coverage from the initial 5.8 general population to 83 by September. Yes. You remember we had those groups. And for the teachers, we moved to 79% from barely 1%. For the health workers, 97%. Now, the 3% of the health workers left, actually we know them by name. Because I had a book with me as a DHO having all the names of the health workers, not with bad intentions, but to monitor progress. Of the few that were left, the 3% of health workers, to date we have only 2 left. Only 2 left. All the others have been vaccinated. So our presentation here is to show that, one, when we give our leaders the right information about a health service, they are likely to step forward and do the job for you. Nowadays, when my chairman, the RDC, COW is going on radio, even if I don't go with them, I'm not worried, because they are going to deliver the message as we want. We brief them daily. 2, we as health workers, in different capacity, as a district health officer, as an in charge of a facility, a nurse, health inspector, name it, you have a lot of knowledge and power that you don't need to sit on. Speak out to people, let them hear you. That's the only way we can silence the negative information that normally goes out very, very fast. I am happy in our district we have successfully suppressed any negative information, and the population is coming willingly to receive vaccine. To date, we have received about 22,000 vaccines. We have consumed all of them. This morning, we received 67,564 doses of vaccine for the accelerated mass vaccination exercise. And this, we are sure we'll consume it in 1 week, working together with the leaders and the community. I thank you for listening.
Thank you very much, Dr. Dennis. Let us appreciate in a bigger way Dennis and the leadership of Lamu District.
Thank you.
That was great work done in accelerating vaccination coverage by way of involvement of the district leadership. So I request that you keep the questions and comments, and then we go to the next presentation. I do not know whether the next presenter is ready. Has Rachel come? So Rachel, we agreed that you take only maximum of 10 minutes, but if you can do it in 7, the better. So Rachel is going to take us through a presentation on pregnant mother adherence tracking system, PMATS, increased SRMNH services uptake in CHAI program districts. I want to believe this abbreviation is sexual, productive, maternal, neonatal, something, isn't it?
Yeah.
But she'll tell us anyway. Okay, so Rachel, you have the floor.
All right. Good afternoon, ladies and gentlemen. All protocols observed. Like he mentioned, I'm Rachel Najemba. I work with Clinton Healthy Access Initiative, just located in Kololo. I'm here to present on how the pregnancy mother tracking. I beg your pardon? Okay. This is next. All right. I'm here to present on how the pregnancy mother adherence tracking system has supported in increasing the uptake of sexual, reproductive, maternal, newborn child health. Clinton Healthy Access Initiative has a couple of programs that are being implemented nationally and at subnational level. But for currently, particularly now, I'm presenting on behalf of the SRMNH program. We are looking at so many objectives. Excuse me, I need some help. Has a program. We focus on 6 objectives. One, looking at creating awareness and knowledge on the uptake of SRMNH services in the CHAI 6 supported districts of Kasanda, Mitiana, Mubende, Kakumiro, Chibale, and Kagadi districts. We are also looking at increasing the access to and quality of sexual, reproductive, maternal, newborn, child health services at community level. We also focus on emergency medical transport, then also increasing the coverage of trained and mentored health workers in the different thematic areas, as well as also focusing on logistics and data systems. But for now, I'm presenting on Objective 2, which is looking at the access to and quality of community healthy services. Just failing. It's not working. Okay. I think it's a bit slow. I've already finished talking about that. As we are beginning as CHAI at the baseline in the 6 districts, we realized that even though there was a high first ANC attendance at 84%, but antenatal in the first trimester was only at 13%. Then the institutional deliveries being at 45%, while postnatal at 6 days being at 5%, whereby you realize that we lose most of the babies within that period of the 28 days, and postnatal 5 days is part of it. Then also, when we did a further assessment in 2019 June, we realized that 44% of the deliveries in our supported districts occurred in the community level. But again, we also had to know, why are we having low antenatal attendance during the first trimester, the low institutional deliveries, and the postnatal attendance? Some of the barriers that we had limited awareness in the districts regarding the importance and benefits of antenatal attendance, delivering at home, delivering at the healthy facility and a skilled health worker. At the same time, most of our mothers in these 6 districts deliver from the community. There are so many TBAs around there, and also they didn't know any benefits about the antenatal, postnatal at 6 days. But as CHAI, we work together with Ministry of Health and the districts to implement the pregnant mother adherence tracking system. And it came at the right time when COVID had really affected the communities, whereby mothers were unable to access the services. And here we are. We worked with our district leadership to bring the community together and the services so that our mothers are able to access them on time. How did we work with the districts so that we implement the PMATs? We worked with the districts and trained the VHTs, but additionally, out of the VHTs, we pulled out the parish coordinators, who are the supervisors of the VHTs, to do more follow-ups of the pregnant women that were in the communities. They did not stop at identifying them, referring them, but they continuously ensured that these mothers, right from the time of pregnancy, up to the time of delivery at the postnatal period of 6 days, mothers accessed all the services. We still further went and worked with the district, developed the training tools, distributed them across all the 200 parish coordinators, even the health assistants who were there, supervisors. And at the facility level, we also worked with the facilities to ensure that they share the lists of parish coordinators, not only to the mothers, but also in the entire department, so that they are able, whoever identifies a pregnant mother who is not in the pregnancy tracking tool is also entered. And among that group, we have the group antenatals. Those mothers, most of them were not enrolled in the PMATs, but again, the health workers at the facility level ensured they are being entered. Then at the community level, the VHTs identified the pregnant women, shared the list with the parish coordinators who did further follow-ups for these mothers, educated them on the benefits of attending antenatal, delivering from the healthy facility, attending postnatal 6 days. That is the copy of the tracking tool for the parish coordinators. It has different thematic areas that they were filling in. They put the name of the mother per column, and the row has all the antenatal visits that the mother has to attend from the time of start until she delivers. So after this form has been filled, at the end of the month, they summarize the reports, share with the health assistants, and on a quarterly basis, we collect these reports together with the district and also see where things are not going on well, so that we address the challenges that the VHTs, the parish coordinators and the VHTs are encountering. The next slide shows how the PMATs has really helped in improving the uptake of the ANC, the institutional deliveries, and also the postnatal at 6 days. That is how far we've worked with the district and achieved the success of the pregnant mother tracking system. What lessons did we learn? We realized that when we worked with the parish coordinators, because they were doing an extra mile of following up these mothers one by one, they were able to educate them on every information that they did require, so that they are able to attend antenatal, deliver from the healthy facilities, and as well as bring the babies and themselves for postnatal. At the same time also, we realized that training the parish coordinators, the healthy assistants, we were also building the district system. Because when we pull out as CHAI, how should we ensure that continuity is really taking place and ensure that the healthy facilities maintain what they have already achieved? We also increased the demand generation, because this is the reason why we see those numbers. If you increase the demand generations, the communities are aware what services are there, even to the mothers who had not previously attended their ANC services. And above all, to the healthy center tools that are closest to the communities. Because when you realize during COVID period, most of the transport services were halted. Everyone had to get access from the LC chairpersons at the local communities. And here is when our parish coordinators were able at least to refer these mothers to the closest facilities, which are the healthy center tools for the services. Even when you see the mandate was shifted from the LC chairpersons at the community level to the RDCs, still the coordination and communication between the district, the facilities, and the community continued, so that the mothers would be able to access the SRMNH services. And in conclusion, we realized that when we are able to work with the district teams, the pregnant women are able to access the services on time and also increase the numbers. But at the same time, we have been able to work with the district and pave a way for sustainability after them realizing how PMATS works. We've worked with them on the different methodologies to sustain it. One of them is the utilization of RBF. All our districts, our RBF facilities, we made sure we took them through the RBF component because it has the community empowerment. It is one of those things that are key for the facilities to create awareness. Yes, the parish coordinators per district, they have on average like 78, 80, but at least each facility has a package for all the parish coordinators for that extra role that they are doing so that the mothers are continuously followed up. Thank you.
Thank you, Rachel. Kindly keep your questions and comments. Thank you again for keeping within time. May we have the next presenter on enhancing uptake, on enhancing the uptake of oral HIV pre-exposure prophylaxis services among female sex workers in Uganda by Jenkins. Is Jenkins around? Okay. If you can do it in 5 minutes, that's better.
All right. Good afternoon, ladies and gentlemen. Okay, before you, I'm by the names of Obotanga Jenkins, and I work with the Makerere University School of Public Health METS program as an M&E technical advisor. I am here to discuss an abstract entitled Enhancing the Uptake and Retention on Oral HIV Pre-Exposure Prophylaxis Services Among Female Sex Workers in Uganda. First and foremost, let me give a preamble into how this came about. I believe some of us may not know. In 2015, that is to say, World Health Organization came up with oral PrEP as a key biomedical prevention strategy for the most at-risk populations. And this was adopted 2 years later by the Ministry of Health. As you can see, Uganda adopted these prevention strategies for the key populations in 2017. In Uganda, key populations, there are certain categories of key populations, and these are the FSWs, those are the female sex workers, TGs, those are the transgender people, MSMs, those are the men who have sex with men, PWIDs, or commonly known as the PWIDs, who are the people who inject drugs, and the PIPs, those are the people in prisons and other enclosed settings. So Makerere University School of Public Health METS program, in collaboration with the MOH, developed a performance monitoring system for the National PrEP program. This was aimed at improving its uptake by these key populations because we feel these key populations are the biggest drivers of HIV/AIDS. So what did we do? We designed an electronic web-based PrEP tracker and dashboard, which is built on the DHIS2 framework. It captures individual level data, and it is currently used by all PEPFAR supported PrEP sites in the country. Additionally, we did not stop there. We went on to carry out a capacity building model where we trained health workers, on-site coaching, troubleshooting, and establishing a peer-led network that would help and increase follow-up of clients. So this is, ladies and gentlemen, this is simply a schema of what the KP/PrEP client tracking system looks like, from when the client comes in up to when analysis is done. So what benefits does this monitoring system have? It helps us track all clients using unique identifier numbers. So we can track clients who miss appointments, and we can follow up on those clients to enhance their next visit days. We monitor services given to each individual client in real time. It also helps us extract PrEP cascades and other indicators. It also enables the continuous analysis and reporting on KP data and PrEP data. So the objective of this paper was simply to estimate the uptake and estimate the uptake and retention on PrEP amongst female sex workers. So what methods did we employ? We extracted data from the KP/PrEP tracker. We performed a retrospective cohort analysis of data of female sex workers enrolled on PrEP between 1st October 2017 and September 30th, 2020. We calculated the proportion of the sex workers screened, initiated, and retained over this period of time. And we are going to present a trend analysis of results using line graphs. So this is what we have found so far. From when we came up with the performance monitoring system, we can see that the number of sex workers who have been screened has improved over time. The number has improved from, I think, 5,494 initially to 65,182 where we are now. And with that meant there was an increase as well in eligibility, because when you're screened, they still have to find, even as you're screened, you have to find out your eligibility. You have to be eligible for PrEP anyways. And from there, initiation status also comes in. So we find that those two improved as well. However, when it comes to the retention, because female sex workers are, for lack of a better word, not easy to deal with by virtue of their trade, of course, we are having issues with retention levels. And that's why we find that the proportion of retention rate is relatively low compared to the other indicators across the time periods. And this, we noted, and we feel the Ministry of Health will have to come up with interventions to come and try and address this. So, in a conclusion, we found that, as you have already seen, the uptake of PrEP amongst female sex workers over time greatly improved. However, not all is glory. The current retention levels of PrEP at 3, 6, and 9 months is still low. So we really feel, and yes, we acknowledge that their kind of trade is a difficult one because they are very mobile population. They move to where the business is and where the money is. And we acknowledge that that may have caused problem with tracking them, but we feel the National PrEP program should focus more resources on improving retention rates on PrEP amongst these female sex workers, because they are a very important driver of the epidemic, of the pandemic right now. Well, allow me acknowledge everyone you see up there, because if it wasn't for any of their works, we wouldn't have gotten this far. We're trying to deal with HIV/AIDS in the country. Thank you very much.
Thank you very much, Jenkins. There you have it. Increase of uptake, but retention remains low. Some questions for you will be coming. Let's quickly go to the next presentation by Martin, his representative. And this is going to be on early experiences from the 6 learning districts implementing quality of care initiative for maternal and newborn health in Uganda. So Elizabeth, you may have to introduce yourself.
Good afternoon, ladies and gentlemen. I'm Dr. Namagala Elizabeth. I'll be making the presentation on behalf of Dr. Martin Sendiona. I work as a quality improvement advisor under the SCAP department. Yeah, so my presentation is about early experiences from the 6 learning districts implementing the quality of care initiative for maternal and newborn health in Uganda. I think we are all aware that in Uganda we've had an increase in births attended to by skilled providers, which is at like 73% according to IUDHS 2016. But this has not resulted in a similar reduction in maternal and newborn deaths. And the main reason being poor services, poor quality of services. The MNHS services, the quality is so poor that it does not, going to a facility does not ensure that you will actually survive. So the services, the quality of services has led to high morbidity and mortality. And we've identified that the period around childbirth is the one that is very critical for saving the maximum number of mothers and newborn lives, and for preventing stillbirths. So this is the period that we wanted to focus on. And then following the release of the WHO guidance in 2016 for quality of care for maternal and newborn health services, around that time of childbirth, Ministry of Health with partners embarked on improving the quality of MNH services in the country and targeting the period of childbirth. And based on the adopted 8 WHO MNH standards, or maternal and newborn health standards. So it's in line with this that Uganda is participating in the Global Quality of Care Network for improving maternal and newborn health, whose goals are to reduce facility-based maternal and newborn deaths by 50%, and also to improve the experience of care for mothers attended to. The Global Network for Quality of Care for MNH has broad strategic objectives that are guiding countries in implementation. The 4 strategic objectives are about improving leadership for MNH quality of care services by strengthening the leadership institutions that are improving quality of care. Then the other one is on action, accelerating and sustaining implementation of quality of care improvement for MNH. So the network looks at those strategic objectives to ensure that there's leadership, there's action to sustain what we're implementing, and then also that there's strengthening of learning for facilities that are implementing by facilitating learning and sharing of knowledge generated from implementation, and then also strengthening accountability, which is very, very crucial, even as we implement quality of care for our country. The implementation of MNH quality of care in Uganda was initiated in 6 learning districts, and it was based on the WHO MNH quality of care standards, which have 8 domains. And these domains are very broad because under them, there are many, many standards under them, sub-standards under them, and measures of quality that are very, very broad. But in summary, the domains for the MNH standards are use of evidence-based practices for routine care and management of complications. The second one is about actionable information systems, ensuring that facilities have active health management information systems. And then the third one is about ensuring that there's functional referral systems in our MNH services. And then the fourth one is a new area. It's about effective communication to our mothers when they're admitted in care. And then the fifth one is about respect and preservation of dignity. And the 6th standard is about emotional support. These mothers who are pregnant, when they come to our facilities, they need to be given emotional support. And some of this is in terms of allowing them an attendant of their choice to support them. So standard 4, 5, and 6 are about the experience of care for the mothers. They support the experience of care for mothers, which has been found that if it's good for mothers, the outcome of their pregnancy will be very good. So number 7, standard 7, the domain is about having competent and motivated human resource, which includes their training, retention, motivation. And then standard 8 is about ensuring that we have essential physical resources for MNH, which includes the drugs that are necessary for the services. It includes the water and sanitation services, the physical infrastructure of the maternity units. So the standards really spell out a very comprehensive status that should happen in all these facilities that are providing MNH services. And that's what we embarked on. And for implementation, we followed the key steps. And the first one was about selecting the 6 learning districts. We selected 6 districts, which was Shema, Noya, Kamuli, Kasese, Chiliandongo, and Hoima. And we selected them because they were already partners that were willing to provide funds to support the implementation of these standards. And we selected 18 facilities, 3 from each district, and we targeted a hospital, health center 4, and a health center 3 for each of those districts. We engaged leadership of the district and also implementing partners to ensure successful implementation. And the ADHO for MCH was charged with spearheading implementation at the district and facility level. And then we also carried out baseline assessment to know how the services are before implementation. And we assessed common MNH indicators that had been adopted for the country. We also trained around 300 frontline health workers for maternal and newborn health services in these 18 facilities. And then that was followed by setting up work improvement teams in the MNH area. That happened in December 2020. The other steps that we followed was development of facility CQI projects to address performance gaps that were found at the baseline assessment. And these CQI projects were based on the adopted WHO standards, following those domains that I've just presented. And then there was also supposed to be follow-up of trainees who had been trained through mentorship by central teams, every 6 months by central teams, and every 3 months or quarterly by district-based MNH teams led by the ADHO. And then facilities also had training in essential newborn care to support, to give skills to the frontline workers working in the MNH setting. When you do the baseline, we found that these 18 facilities had high facility deliveries, which on average were above 70%, but the quality of MNH services was still low, and they had high maternal mortality ratio. Neonatal mortality ratio was high. They still had high numbers of fresh stillbirths and macerated stillbirths, and inconsistent use of pathographs. So we set out that facilities picked projects to support addressing of these gaps. Facilities were supposed to address the clinical gaps in management of routine and complex MNH care. So some of them, the partners actually supported trainings of these MNH frontline workers to acquire these skills. And then also there was absence of some of the key commodities and supplies for MNH in many of the facilities. There are also gaps in use of data for learning and decision making, and also weak leadership and priority setting for the MNH services. There was also lack of adequate resource allocation for MNH services in these 18 facilities. So some of the QI interventions that the 18 facilities took up was that across all facilities, there was an agreement that they will look at the 60-minute decision to incision time as a response to emergency cases. Then also across all facilities, they ensured correct and timely use of pathographs to ensure labor monitoring. And also across the 18 facilities, there was active management of the 3rd stage of labor, ensuring presence of standard-based processes for triage and labor, delivery, and postpartum care. And also they identified champions for active management of the 3rd stage of labor. They also supported referrals, ensuring a central pool of ambulances was available and emergency teams to accompany the patient once referred. The results for these across these 18 facilities overall, because we set out to reduce institutional maternal mortality by 50% and also to improve the experience of care and also to reduce newborn mortality, institutional newborn mortality. So these are the things that we went out to look out after 1 year of implementation. And we found that there was a 24% reduction in institutional maternal mortality across the 18 facilities overall. And but however, there was a 43.4 increase in institutional neonatal mortality across the 6 learning districts after 1 year of implementation. The other result was that facilities had training on correct pantograph use, which led to an increase in correct use of pantographs by maternity staff. And of the 18 participating facilities, only Hoima had a reduction in fresh and macerated stillbirths, but the rest of the facilities had an increase in newborn deaths. And then due to the COVID lockdown, the mentorships that had been planned were delayed because the facilities were trained in December 2020. And then the time when we were supposed to go for post-training mentorship, that's when the first lockdown happened in March. So there was a delay in all the mentorships that were planned after the training of the staff. So instead of going after 3 months, some of the facilities were mentored after 6 months. And then also the quarterly mentorship of frontline providers by district staff were also delayed in some of the districts due to the COVID lockdown. The other results was there was improved delivery management because of the introduction of simplified pantographs. And then also there was improvement of MPDSR audits that brought attention of senior management to the challenges of neonatal survival in their facilities, such as the deaths that are due to birth asphyxia and the processes contributing to birth asphyxia. But still, this did not reduce the newborn deaths as anticipated. Then also districts across were supported to hold quarterly follow-up meetings, which brought together frontline health workers with their districts and health sub-district in charges to review key performance indicators, identify gaps in performance, and plan solutions and monitor implementation of these. There was also innovations in use of space. Facilities were created privacy by partitioning their rooms with curtains so that there's privacy, so that they can improve the experience of care for the mothers. So these are, this is the graphical representation of what I've just said, that when you look at the institutional maternal mortality across the 6 learning districts, you can see that there was an overall 24% reduction in maternal mortality ratio. I think you can see that each district had a different percentage in reduction. I think Kamuli, instead, although there was an overall reduction in maternal mortality ratio, for Kamuli, there was an increase in maternal mortality ratio, mainly because of there was a COVID-affected Kamuli district, much more than this, because some of the staff got affected. And then there was some problems with handling of clients in the hospitals that were participating in that were part of the 18 facilities. But overall, there was a reduction in all the facilities, as you can see. Noya district had a 43% reduction. I think they had the highest. And also Chiliandongo had 82% reduction in institutional maternal mortality. For institutional neonatal mortality rates across the 6 learning districts, as I've shared already, increased by 43.4% across all districts. It was only Hoima that had a 30% reduction in neonatal deaths, as you can see. I think you can see that Kamuli had the highest increase in neonatal mortality of 87%. So some of the positive findings was a reduced third delay by 60-minute decision to incision, because facilities try to reduce the time it takes for them to do a cesarean section once it's been sanctioned, as you can see. They created awareness of situation to all facility staff, so that every time there was a Caesar sanctioned, they had to time and ensure that it's done within 60 minutes, and that improved across the facilities. There was also improved postnatal visits, and this is just Chigumba Health Center 3 in Chirandongo district. You can see that they tested a number of changes. They identified postnatal care staff to look at mothers who come back for postnatal care at 6 weeks. They identified mothers with specific risk factors and retained them in the facility. And then also they provided soap and basins to mothers to ensure that they come back. And then the in-charge maternity asked to review, adopt, and integrate, strengthen PNC within existing services. For example, PNC was integrated in immunization services and also in IMCI under 5 clinics. So that caused improvement in postnatal care in some of the districts and facilities. This is still the same data that showed an increasing number of mothers C-section within an hour, and that is for Anaka General Hospital in Noya District. The same data presented differently. Then performance, we followed up performance even beyond 1 year, and we saw that in most of the 18 learning sites, performance remained poor for pre-discharge neonatal deaths and fresh stillbirths and macerated births in the 3 quarters, January to September 2021. However, some of the indicators were well performed. For example, performance was above average for postpartum hemorrhage case fertility rate and maternal deaths per 100,000 live births for the same period. So you can see where there's red, that's poor performance, but for each of those indicators, it is, for each of the indicators, I think you can see that facility stillbirth rates is the extreme right column. You can see so much red. Facility stillbirth rates, facility stillbirth macerated bed, facility stillbirth rate for macerated, and facility stillbirth rate for fresh. I think that one remained red across districts. But you can see that PPH case fertility rate, which is the second column, you can see that there's green across the 3 quarters between January to March, April to June, and July to September. But the newborn indicators had not really improved even after beyond 1 year of follow-up on these facilities. I think this is still another graph showing how the facilities were performing. The 18 facilities were performing between January to September 2021. I think you can see that percentage of women discharged postpartum with contraceptive method of choice remained poor. And then also percentage, I think you can see red across all the 6 districts. And then percentage of eligible neonatal babies that were initiated on kangaroo mother care was still low, although it had improved. It improved in the last quarter between July to September across most of the facilities. So you can see that these facilities still need to be supported. And then I think the next slides are just about the challenges that we had and how we plan to address them. As I mentioned, one of the second objective was to improve the experience of care of mothers who came to attend delivery services in those 18 facilities. That one of the hospitals, Anaka, did exit interviews, client exit interviews, and the data shows that there was improvement in the quality of MNH according to the clients themselves. Okay? Facilities were able to get feedback from mothers and improve services. Okay? And they were able to counsel staff that were reported to be mistreating clients. And then also they were giving health education on admission, on proper use of facilities. And then also some of the issues raised, like maybe dirty bathrooms, were addressed because they got that feedback from mothers. And as a result of addressing the challenges mothers met when they came to facilities, there was an improvement in the number of deliveries in facilities, as you can see. Anaka Hospital deliveries between July 2020 to June 2021 steadily increased over that time. They were just affected by general elections around January 21st, but over time you could see that the number of deliveries improved over time. So the challenges that we had for these 18 facilities was adherence to SOPs for COVID-affected, timely follow-up and mentorship of the frontline health workers that had been trained in these 18 facilities. And then there had been fear of contracting COVID among healthcare providers that affected delivery of services. And then competing health programs engaging the same frontline providers created a temporary reduction in the workforce. And then the COVID-19 pandemic among health providers led to closure of some of the facilities, like for example in Kamuli. At one time the facility was not operating as it should because some of the staff got COVID. A few of them I think died, and that affected service delivery. A few health workers in the 18 facilities, as I said, got infected. From our findings from these 18 facilities, you can see that reductions in institutional maternal mortality across the 6 districts were on track because at least for the institutional maternal mortality reduced. However, newborn mortality rates increased instead. And then the anticipated reduction in newborn mortality was not recognized, probably due to inadequate inputs into the newborn services in the 18 participating facilities, as outlined in the MNH standards. There is such inputs that we thought would be put by the implementing partners. Some of them did not happen. Like, for example, the quarterly CQI mentorships and coaching of the trained staff. Some of the MNH equipment was lacking. There was lack of NICUs. Some of them were never set up, which are all very critical for improving MNH services, as outlined in the adapted MNH standards. And then also the COVID-19 restrictions also affected the scheduled follow-up and mentorship of frontline health workers. So in conclusion, inadequate investment in the necessary health system inputs for MNH led to suboptimal results from implementing MNH quality of care in the 6 learning districts. And then also, we can conclude that implementing CQI activities without ensuring necessary MNH inputs did not cause the targeted reductions in maternal and newborn mortality. So QI alone may not cause all the improvements we want. We want to ensure that there are inputs, and actually the MNH standards that we adopted stress ensuring that there are inputs. If staff needs to be trained, they should be trained. If there is equipment, you should have, actually they support institution of, or setting up of NICUs, newborn intensive care units, where they're supposed to be, especially at hospital level. All those, once they're not there, it's very, very hard to address some of the things we set out to address. Then finally, the COVID pandemic adversely affected implementation of MNH quality of care in the 18 participating facilities by interfering with access and utilization of MNH services, and by delaying scheduling of mentorships, visits, and follow-up to these participating facilities. So we recommend that to achieve reductions in maternal and newborn mortality, the country should ensure availability of health systems inputs for improving MNH services, as outlined in the MNH standards. And then the second one is that COVID-19 preventive and control measures need to be aligned with health service delivery to ensure continuity of MNH services, because I think MNH services suffered the most under this COVID pandemic. Thank you.
Thank you, Elizabeth. May we have the last presenter? Do we have Joy? I hope, Joy, you're going to take a short time. I think Elizabeth's presentation needed an hour. I'm happy she tried to run through quickly. So I don't want us to take an hour. This session, much more than an hour. Please, if you can, make it in the shortest time possible.
Yes, I'm going to manage the time. I'm actually presenting on behalf of Joy Batusa. My name is Rosette Virungi. I work with Clinton Health Access Initiatives. And what I'm going to take you through is our work on improving and increasing uptake of long-acting reversible contraceptives especially in the period when we had COVID. So there are some things which I'm not going to go through, but I must go through some of the key things. As we all know, family planning is a known high-impact intervention for reduction of maternal and newborn mortality. And if implemented, it can contribute to that worldwide, it is known. But when we went to the 6 child-supported districts, we found out that there were some barriers, like Dr. Elizabeth has alluded to. We had barriers on inputs in terms of logistics, the methods, and all the consumables that are required to provision of family planning. There was a problem in essential equipment that they needed and other medicines. And there was a lack of community awareness of family planning, but also myths and misconceptions, especially that are associated with long-term family planning contraceptives. What we actually did, because we had an assessment and found those gaps, we implemented some interventions, and some of them included training of health workers on provision of long-term contraceptives. And then we also did quality improvement training, and this time we did it on site. And then we also did data-driven mentorships, whereby we did the clinical mentorship, but also made sure that we implement quality improvement for health systems strengthening. And then we gave them the protocols and the guidelines to use during their counseling because of the myths and misconceptions that were prevailing. And then we supported them to start up quality improvement projects around provision of long-acting reversible contraceptives. And then we also input in terms of catalytic procurement of the key equipment that were lacking. And then to spread learning across the facilities, we took them for learning sessions, and then it helped them to be able to share what works well, and then be able to try it out and implement it to scale if it has worked out for them. So what's very important to note is that when we're doing the mentorships, we looked at all the things that one would need, not only for skills, but we also looked at the documentation, we looked at supplies, we looked at the enabling environment that all of us have been speaking to make sure that in case there is a problem that they can fix, we support them to fix it using the available resources. And then as facilities, they were able to test some changes. Maybe something I've forgotten to tell you is that all the time we've been implementing quality improvement at higher level facilities, starting with hospitals, for instance, regional referral hospitals, 5S, that's in regional referral, quality improvement at that level. Then you go to the hospitals, then health center 4s and 3s, and we have always forgotten about the health center 2s. So we saw capacitating of the health centers to provide these services as a game changer during the COVID-19 pandemic. Because as we are all aware, a health center is the first interface of a unit with a skilled health worker. People are not able to move, although the services were available at higher level. But fortunately, because our intervention included the lowest level of care, the health center too, we were able to increase access to these services, and mothers were able to go for it because the health workers were prepared. Prepared in terms of training, prepared in terms of logistics. They had even organized their work environment to be able to provide the family planning services because there are midwives there, enrolled midwives, and they are able to provide these services if capacitated. So what they did, they came up with different changes, some of which included telling mothers during antenatal, talking to them, educating them, and counseling them. and then documenting the method of choice they've chosen and putting it on their mother's passport. The antenatal card we know. And then at every visit, they talk about the family planning they chose, checking in to see whether the mother has changed or they are still in line and still want to continue with the method they chose at the beginning. But then because of the male involvement and decisions for men, you know, men remain men. They are decision maker. Even when you are the one to take up an IUD, even when you want to do an implant, the husband must consent. If they don't consent, we've seen scenarios where mothers have been chased and they have gone to facilities at night because the husband has sent me because they found out that I took a method. So facilities took a deliberate effort to involve them by writing to them notes and telling them what they are going to get when they come to the facilities, and then they were able to be cancelled. So there is one thing that the teams did right from health center tours, tagging the postnatal visits and family planning to the birth registrations and making sure that the mother knows that when you come back, we are going to register your baby, we are going to examine you, and we are going to give you your family planning method, because then you would have already consented with your husband. So some of those changes that teams implemented at all levels, very important to note, at all levels, health center to the regional referral hospital, they gave us some results. These are absolute numbers, and the facilities that implemented and gave us these results were 131. So we realized that at the start, the facilities who were ready to provide the long-acting, especially the implant, because we felt the implant is easier at a lower level like a health center 2 compared to the IUD, although even the IUDs are being provided in our facilities. There were only 51% of the facilities. And then the facilities that we are providing that had access points. In access points, what do we mean? There are equipment, the methods are there, the health work is trained, they have privacy, innovatively created. At the beginning, it was about 25% of the facilities. But by the end of last year, 96% of the facilities, we had the access points for provision of the long-acting contraceptives. And then what did we learn? What we learned is that implementing quality improvement interventions at the lowest primary level, primary health care level, increases access. Because, trust me, where we work is the villages. For us here, we can afford a dress we want to come to Speak Resort. But our mothers there, even the gomeses they have, or the chitenji they have, may not enable them to cross a trading center. So at times, some of the reasons they don't want to leave to go to a healthcare worker is because of that. They have babies they can't leave home because it is a long distance. They need money, but again, they don't have the money, although they need the service. So taking it closer to them is very, very important. And before you take it, ensure that there is preparedness, there is readiness to provide the service. These midwives can do it. Just as the doctors can do, so are the midwives. The other thing we realized is that when you capacitate the midwife, they gain confidence. Initially, they could counsel mothers, but drill more on these methods. They actually gave testimonies. Because they are able to give the injection, because they can dispense the pills, they could speak more to that. Counseling less on family planning, IUDs, counseling less on implants. But when they gain confidence, they are able to provide the services the mother needs. What are we concluding? That there is an opportunity to build lack provision, capacity at the lowest level of care, And this one, we saw it increasing access by diversifying the service points, and it decreased the congestion at higher levels of care. And when it comes to that period, we all know where transport was a problem, movement was a problem, it was a game changer. Okay. I thank you so much for listening to me.
Thank you very much, Rosette. May I now inform the participants that we are now going into the discussion, and I would like to invite the presenters to come forward. Elizabeth, Jenkins, Dennis, Rachel, Rosette, please come forward and take questions, comments. You may have to take notes from colleagues who have experienced some of those things. I want us to take strictly 10 minutes in this session. We need to save time. We need to cover what needs to be covered today. I'm informed that there won't be poster presentations. We shall straight away go into the next session. So, by way of guidance, I want to take hands from this side first. Since there are few, I'll combine. There are not too many hands. So I'll give you numbers, and that's the order in which you will ask questions. And please, when you're asking a question, be specific. If you're asking Dennis, mention it. So let me stand up. I like to start with backbenchers. They are not there here. So we shall have 1, 2, the lady behind, 3, 4, 5, 6, 7, 8. We shall have only 2 rounds. So this is the first round of questions. So in the same order, please.
So thank you very much, the presenters. I'm Nelson Onakalit from Rice North Acholi, USAID. One of my questions is to Dr. Dennis Ochula from Lamour. Thank you for your presentation. I just have one question for you. That with your zeal, with your innovation, and skills in management, I also want to assume that you are the chairperson for DHOs in Acholi sub-region. How can you motivate other DHOs also to act the same way you have done? So that it's only not Lamour shining in the region, but the entire Acholi sub-region. Thank you. Then the second question, I have forgotten the name of the presenter. Yes, but she talked about postnatal care, first trimester attendance, ANC. But on postnatal care, you said from the baseline, you had only 5%. And throughout your discussion, you didn't now mention anything that was done, especially for postnatal care improvement for the one of 6 days. So can you please tell us what you can do differently? Because that is the main thing which is affecting the entire country.
Nelson.
Thank you.
Nelson.
Yes, please.
You don't remember her name, but is she among these ones?
Yes.
So who is it?
The one next to Dr. Dennis.
Oh, this is Rachel.
Rachel. Oh, thank you. Thank you, Chair.
Okay.
Yeah, thank you very much, presenters. Chakwa Richard Juko is my name. I work for USAID LPS Tasso Acholi. I have questions to Rachel Najemba. One of the biggest hiccups to your activity was the presence of TBAs. And in your strategies, you did not mention anything to do with traditional birth attendants. I wanted to understand what did we do to ensure that we motivate them and then they stop, conducting deliveries at that state? Then number two, apart from the trainings that you did provide to the parish coordinators, what other motivation strategies did you provide to ensure that we take the processes? Then the second question goes to Jekin Tanga Obo. You spoke about the tracker. I just wanted to understand a little more. What, in addition to the tracker, increased? What are those key activities that led to the increment in PrEP uptake? Because to my understanding, the tracker, yes, gave us the statistics to ensure that we track retention. But in terms of access, there might have been some other strategies that were put across there. Thank you.
Thank you. I'm called Shanifa Kevin from Navy. I'm an enrolled midwife. My question goes to the last presenter. I don't know her name. I did not pick. Joy?
Rosette.
Rosette. She presented very well about family planning. And I liked all that she presented. I wanted to marry that idea so that I can take to my home district too. I wanted to know how she fully brought in men, because it is hard to pick men to come. Men have negative attitude towards family planning in providing those services. How have you convinced men to escort their women to the facility for family planning services so that they don't cause those gender-based violence and all those things stops? Thank you.
Madam from Nebi, she told you that they wrote letters, invitation letters to the men. Maybe you would want to know whether actually men respected the invitation letters, isn't it? Maybe she will speak to it, but I was following, and she said they wrote specific invitation letters. I think men respect that, but she's going to speak to it. Now, the other one, yes?
Thank you very much.
But gentlemen, I don't see you sanitizing that mic. Eh? I don't want you to spread COVID.
Thank you very much.
Please get one.
Emmanuel Ainebiona is my name, the Senior Public Relations Officer at the Ministry of Health. I took interest in this study presented by Jenkins, and I would want to know whether their study just looked at uptake, because it enhanced uptake, so what? So I wanted to know the so what. Did this increased uptake translate into prevention of transmission? I wanted to know whether you intend to widen scope to look into the effectiveness to this of this uptake by the female sex workers. Thank you.
Okay. Please sanitize and give the next one.
Yes. Thank you for the presentation, the presenters. My name is Dr. James Sabach. I work with Right North Acholi. I would like to ask Dr. Ochula one question. We know you're doing very well in Lamu to ensure vaccination of the population is improved. You also mentioned in your presentation that you have about 2 health workers who have not yet vaccinated. It is good you know them by name and physical. What I also presume you possibly interacted with them. What are the reasons, some of the reasons that possibly they shared with you that is hindering them from taking up the vaccine? Then my second question goes to my friend Obong on the issue of PrEP. You talked about retention, as my previous colleague alluded to. I would like to know what efforts did you put in place to ensure those one who are lost follow-up brought back to care? And would you please share with us what you've done to ensure that those who are lost follow-up are brought back? Then I was also thinking, is it possible, because these are mobile population, they are not stationed in one place. My experience is that most of them are truck drivers, sex workers. They are not in one place. Do you have anything that you put in place to track these people? If one is in Soroti, then possibly the person was enrolled in Atiak in Amuro. Do you have any idea of how to follow these people up? Thank you.
Good afternoon, members.
Good afternoon.
I'm called Mafavi Twaha Nangoli from Tasombali. It's a comment and a point of information to Dr. Dennis. I was a CHOI mentor in Kitugum recently. Kitugum is your neighboring district. And I would wish that you're using in your district can also be used like leadership by example in vaccination for COVID. If at all we would also use this in VMMC, medical health workers who have refused to be circumcised. But if they can lead by example, same to other things like combating GBV, combating early girl-child pregnancies, then family planning, and among other things. I think if we roll this approach to all facets of health care, get proper and good health outcomes. Thank you.
Very much. My name is Winfred Tudia Singra. I work with Kaloribanga Hospital Nyachibale, located in Lukonjiri district. My question goes to Dr. Elizabeth. I want to thank you so much for your presentation. And in your conclusion and your recommendations, you recommended that more efforts be put in to reduce neonatal mortality. You say that 43%, there was a 43% increase in neonatal mortality, but we realize that a mother and child go hand in hand. If we are taking through a mother through pregnancy, ANC, and then at the end of the day we are losing the baby, it's really a big gap. So did we really try to find out what is the root cause for these deaths? Because we don't want struggle, then at the end we lose it all. What is the root cause for these neonatal deaths? And if at all we have had the root cause, have we really tried to find other interventions other than waiting for the word from above? Thank you very much.
Yeah, I'm John Maogole, clinical officer from Kabaramaido district. For the last presenter, that is Joy. On family planning, I have issues, even health workers, they have myths on family planning. Now, you find that it becomes even a terrible barrier to giving it out to those who may need to consume it, if the health worker doesn't believe in it. So how did you overcome that? Then for Dr. Martin, who was represented, the domains on MNH, part of care, were well shared. I single out the referral system and effective communication. on the referral, you realize that currently, generally in our Uganda, you can refer a case, a mother, but due to constraints, economic constraints, also when you come to communication, the health worker may have limited time to do the effective communication, realize that the client may not get the necessary information to move on to the next level. So there may be the delays. How did you overcome that? For Dr. Ochula Lamo, how did you balance the mobilized masses versus stock? Because most challenges that we faced, you could have numbers, but the vaccines may not be available. How did you manage that? Then the last is for Tanga, who presented on enhancing the uptake of oral HIV PrEP. You pointed out that there was that uptake increase, but retention became hard. So what strategies are you recommending for us to embrace? Because I didn't see you outlining those strategies that you may have brainstormed. Thank you.
Thank you very much for those questions. Right away, I'm advised that we don't have much time, so we are going to end with this round. We shall not have another round. Those of you who have questions, you may have to approach these presenters in person so that they can be able to give you some answers. So starting from my extreme end, please respond to your questions and comments.
All right, thank you very much, Chair. My first question was in regards to the key activities that led to the increase of PrEP uptake and what other strategies were put across. Well, we went on, we had a lot of community interactions in order to kill the stigma that was involved, because we all know that these female sex workers or these key populations have a lot of issues when it comes to opening up. So we had a lot of community interactions through our IPs, of course, our implementing partners. And then we also established a peer-led network where there was some sort of fellow female sex workers who are open to the whole strategy of PrEP, coming up and encouraging their colleagues to enroll for this. My second question was in regards, or was regarding whether the study was just looking at uptake and what next after this. Well, just like any other study, it doesn't aim to stop at this. We are continuously looking at the HIV incidence rates among female sex workers, and we are also trying to relate this to if there are any reductions in incidence rates amongst these populations, and we are trying to look at how this is related to what we did in order to increase its uptake. We are also looking to further the study. At the moment, we keep carrying out semi-annual DQAs to look at how this is helping with reducing the HIV incidence and prevalence rates. The other question was regarding the efforts that we have put in place to ensure that those laws to follow up are brought back. Now, as we all know, these key populations are very difficult populations to deal with. Let us first acknowledge that. We have tried our level best to collect as much baseline information as we can. But Sometimes it works out because we try to follow them up with their contacts that they leave us, and a lot of these female sex workers have someone who they are under. So we try to get as much baseline information as we can to enhance and enable our follow-up. But having said that, it is not the easiest group of people to deal with. So if someone really wants to give you wrong information in regards to phone number, they still will. But we follow the only way that at the moment, we try as much as we can to get as much baseline information that will enable us track them to the dot. The other one is, since they are mobile populations, do we have anything in place to track those people? Well, as I mentioned earlier on, every female sex worker is given a unique identification. So regardless of where the female sex worker or someone goes, because they are very mobile populations, as we all acknowledge, even if the person gives us, say, a different Obotanga Jenkins, and we shall try as much as we can to ask this person questions that are related to age, their area code, so that we can zero down to the fact that they are not the same person before another unique identifier is given to that person. What else? What strategies do I recommend for retention? At the moment, this is a very good one, because this is exactly what we are trying to look at. As I speak, we are still and very open to any ideas. We are still very blue about this. We are coming up. We have some strategies such as intensification of baseline data collection, and the biggest challenge we really have is stigma. So we are trying as much as we can to beat the stigma barrier, because this stigma barrier, so we are trying to get information out there, that trying to let the community know that these are other populations just like us, in order to increase the level of retention, because most of the times they shun PrEP because of the lot of the stigma that is related to it. Thank you.
Yeah, thank you very much. All those who raised questions, directing them to me, there were 4 in number.
Please kindly make an attempt to respond in 1 minute.
Yeah, sure. I will go.
We are short of time.
Thank you. I'll go in reverse order. The first one is from John. Yeah, it is true that we had challenges with stock, but you'll also agree with me that from the month of March, mid-March, up to, I think, around September, the demand was not as high as it has been recently. But even during that time, I am very, very happy to Ministry of Health that we received what we would call supplementary supplies out of the routine that were given to all the other districts, because we wrote twice asking for additional supplies. And we will also redistribute from neighboring districts that were not taking up the vaccines very, very fast, given that they would also expire. So that was how we managed the number that turned up. The other one is from my brother, Mr. Mafabi, how we can also apply this in other areas in our neighboring district. Kitgum is our mother district, is our nearest city. I am happy that the acting district health officer is a young man, very, very vibrant, and is committed. He's about 1 month in that office. We share ideas more or less on a daily basis. I have no doubts that things will change in the right direction in that place. The other one from Dr. James Abaj. The 2 health workers, some of the reasons they gave forward was, one was basically fear, just like other people had, fear of death, because they were not sure of the the quality of this vaccine, like many people indicated. And then the other one was under pressure from our husband. The husband is a teacher. And what we did, working with the DEO, we also teased out the names of teachers who have not yet been vaccinated. We found the husband is also not vaccinated. And we went further to analyze why. We realized that they had recently wedded. So probably they feared dying immediately after their wedding. So we have requested one of our senior colleagues who has additional training in counseling to engage them and eventually have them vaccinated. Now the other, actually, as fate would have it, got infected. She got infected. We supported her under home-based care. We are happy she recovered. And she has agreed that after 3 months, she will receive the vaccine. And the first one was from Mr. Onekalit from Right North Acholi. Thank you for that observation. As you are aware, I was not the president of Acholi region DHOs until some few days ago when we regrettably lost our DHO of Noya. But even before then, she had given me a lot of opportunities to interact with these districts. I remember in Lira, in the month of April, I talked to our colleagues, the DHOs of Acholi sub-region, and in that meeting, Commissioner John Bosco was there, and actually he was the one who suggested that I make this presentation at this level, because I had started engagement with the DHOs in Lira. And since then, I have had 2 radio talk shows in Gulu City, talking to the entire population of Acholi on Radio Rupin. In Kitgum, I think I've had more than 10 radio talk shows. Every day, if you listen to the local radio stations, you'll hear me on radio, either alone or with somebody, mobilizing people on health issues for the entire region. So we are there, and I also continue to engage with the DHOs one-on-one where they need our support and how we can also talk to some of their leaders to support them. You know, sometimes when relationship between, for instance, the DHO and the RDC or the LC5 is not so good, it affects what we have just been talking about. So we are trying to make sure that the team works together, and together with you partners, I want to thank you right now, Acholi. We'll break through. Thank you.
Thank you so much. And for the questions, my first question is about what we did to see that also the postnatal care at 6 days improves. When you look at the way the pregnancy mother adherence tracking system is designed, the parish coordinator enters every mother and captures their details right from the first visit or the first engagement up to the time of delivery, and follow them up until they deliver. Secondly, also the healthy facilities, because we mapped the parish coordinators, as well as right now they are also group antenatals. They do share the lists of the mothers who have delivered to the parish coordinators. And they have even gone beyond to get babies who have also delivered from the communities and refer them for postnatal 6 days. And in that, even the babies who have missed the immunization, they have been able to do what? To access the service. Then secondly, the second question has been about TBAs, what have we done? The first thing we did across the 6 districts, we engaged the different district structures, including depending on the district, the RDC offices, the LC5 chairpersons, then also the administration offices. We had data from the communities because we engaged them in mapping every sub-county or parish that had a TBA and the deliveries that they were conducting. There are some TBAs who were even conducting deliveries beyond the number at the healthy facilities. We did not arrest any one of them, but what we did, the district, even the other sub-county leadership, have had a one-on-one with them. I personally was also invited and visited a prominent TBA who conducts more than 40 40 deliveries in a month, and the facility is like 500 meters away. But now this facility, when you look at it in that district, actually that's Mubende district, Kasambia, the deliveries annually have gone up to 1,000. The TBA also refers the mothers and the babies to the community people, the parish coordinators and the VHTs. We've not had any kind of motivation, but what has been given are the standards of care, that this is how it's supposed to be done, and you don't have it. But this is where I would also request the Ministry of Health, because community deliveries are increasing every now and then, but we don't have clear roles and guidelines, because when you look at most of the TBAs, they have a 5-day training in a particular thematic area, but they keep on utilizing that certificate that they were trained to conduct deliveries. So this is where we call upon the ministry at least to have in the engagements that you have to look into that, and so that if the districts are maybe to go and arrest, I shouldn't say arresting, because we've had maternal deaths at the community level in our districts from the TBAs, to have these people at least brought maybe in court or stopping them that they are not supposed to do what? To conduct deliveries. Then the other thing was about the motivation strategies for the parish coordinators. Of course, we did not want to have parallel systems within the districts, looking at what is happening. Sustainability has to continue. The first thing I talked about was RBF, because we had to take through our facility in charges on the community empowerment component that is in the RBF guidelines. Then secondly, different sub-counties, different districts have gotten different activities that they are working on. We called them at least to map all of them, put them make a list of them, and see what particular, the number of parish coordinators that they are able at least to utilize, engage them as a way of motivating them. But again, at the end of the day, when you look at it, there are not so many parish coordinators per sub-county, and at least most of them were positive and taking on in the different activities. Thank you.
Yeah, thank you very much for the questions. I think I had one question. First of all, I just want to say that you cannot improve newborn services without improving maternal health services. That must go together. However, when we did, we analyzed our data, we saw that actually maternal services have been improved faster than newborn services. For example, you find that probably there's blood everywhere. In all the maternity centers, it's more easy to access blood and all that. But the services for a sick newborn are worse. They are rarer to find. We don't have many neonatal intensive care units. And we are also not doing a lot of newborn analysis of the deaths of our newborns. We do not do, there is more maternal death reviews than perinatal death reviews happening in facilities. I think almost like less than, like if they conduct 10 maternal death reviews, you find half of them, only half of those are neonatal death reviews. So there's more, facilities are doing more for the maternal health than for the perinatal deaths in terms of prevention. And then the other thing also, our findings, I think as you can see, the findings that we got from these 18 facilities were actually majorly negative, especially the fact that we did not see the anticipated reduction in newborn mortality. But we are presenting these results because these are learning sites and we are learning from them, and we're able to learn. We analyzed data and we saw that the investment in newborn health is much less than what we've invested for maternal health. And then the other thing also, I wanted to show that continuous quality improvement alone without addressing the inputs may not be enough, especially when we are implementing the maternal newborn quality of care standards, because these standards, as I said, require you to put inputs. I think you've seen that they must have competent, motivated staff, which is an input. You must have infrastructure improvements. And if these are not addressed, you will not be able to get the 50% reduction in mortality. So that's what we went out to actually show. And it is good that the CHAI presentation came after mine, because you could see what CHAI did to get some of the results they have. They really did a lot of inputs. They trained, they mentored, and when you look at the 18 facilities, We did not do all the things that we set out to do in the first year. That's why our results, we didn't get the results. So that's the learning we are learning. We need to invest more. We need to put the inputs. We need to do the CQY, but also the inputs must happen. And then we are still analyzing data, and that's why we're able to present some of this. But we have a lot of data from those facilities, which we are still learning from, and people are still learning. And we've scaled up to other facilities using what we've learned from these 18 facilities. So there are other interventions that are being tested out, and actually we've seen that even the implementation of these MNH standards needed to be simplified. So we've come out with simplified tools for facilities to guide them. We've come out with a package of clinical care interventions that address the common causes of mortality. So we know what killed most of our newborns and even what killed the mothers in those facilities. So we have simplified the implementation of these MNH standards, and we are finalizing our implementation guidance for these facilities. So we actually have learned from what I've presented, although the results were negative. Most of them were actually negative, apart from the reduction in maternal mortality. Thank you.
Okay, so thank you very much, Chair. Mine were basically two questions. One was about the male involvement, and like the Chair said, yes, it was a problem, but the frontline health workers, especially the midwives, came up with some innovations, and they wrote letters through the mothers, and they were able to, some of them were able to come, although not all of them were able to come. Then the other thing, we realized that, of course, holding meetings with the work improvement teams, that some men could come with their wives, and they stay under the trees, on their bikes, because they were not invited. But then when they realized that, they started inviting them in to sit in and listen to the education sessions on family planning. The other one was about the health workers having minks. Fortunately, this was not a very big problem, although it was there. But because these health workers were trained and followed up with mentorships. When we speak to mentorships, we all understand that we are speaking to the whole person, not only to look at the skill only, but their attitudes and practices, their behaviors, and this mentorship took some time. So for those few people who had some myths, some of them were able to change, but I agree, there were some myths amongst the health workers. Thank you very much.
Thank you very much, everybody. Thank you very much, the participants. Let's appreciate the presenters we've had a very good session, very good cooperation, very good questions. It was very engaging. Thank you very much. Stand by for the next session. Our session is over.
Thank you.
You've not clapped for the chair.
Thank you.
I have been given the honor to invite the chair of the next session. And I was advised that the poster presentations are not there, so the next session automatically starts, and the chair is Dr. Nsungwa Jessica. Is she yet here? Oh, she's over there. Dr. Jessica, you're very welcome. Apologies for taking much of your time. A stronger hand clap for her, please.
Thank you very much.
So the chair is yours.
You're leaving me?
Yes.
So good afternoon, good evening, everybody. And I want to welcome all of you to this last session today.
We lost a lot of time in the morning, but I think we've been able to gain some little time, but still, we are exactly 1 hour late. So at this point, I want to invite my presenters to come and sit up with me here. And I want to invite Christine. Christine, if you are here, please come and take your seat here. And then I want to invite Philip, Patrick, and Patience. So we'll have 4 beautiful presentations this afternoon. Fortunately, 2 of them are very similar, and that means we're going to have a very exciting time to be able to learn from the 2. And my plea is that we will have to spend shorter time because we are
recording in progress.
So I want to request that the members, as they come here, arrange to spend only 7 minutes, and then we'll have very quick discussions. And we should target to leave this place by, at least to end our session by 5:15 because of the curfew and people have to find where they are going to sleep and so on. So you're all welcome here, members of this session, the last session of today. And so I have only one presenter here. I think this is Philip. Is that Philip? Is it Philip or Patrick coming? Okay. So thank you very much we want to welcome our presenters for having accepted to make these presentations and prepare them. This is very exciting for us because this is where the rubber touches the ground in terms of improving our services, in terms of making sure that we are addressing the needs of the people. So thank you very much for your time and for your interest. So I want at this point to invite Christine, if she's already here, to make her submission. The first presentation is on integrating QI approaches to improve perinatal death reviews at Ibanda Hospital over a period of 1 year. We've just been talking about the challenges of improving newborn health, and I think this is a very nice coincidence to start with this presentation. So Christine, you're most welcome to make your submission.
Thank you, Madam Chair. I request that I get a microphone because, as you can see, I can't bend like this. Thank you. So I can be lifting for the interest of time. Can I reach? So I'm Christine Nimwesiga. I'm working as Assistant DHO in charge of maternal and child health. There. So I'm presenting the changes that we have tested in Ibanda Hospital. And this is the only hospital we have in the district, and it is a PNFP. So we tested some changes, and we have realized improvement in perinatal death reviews at the hospital. So even the hospital, we realized it was having high burden of maternal and perinatal death in Ankole region. And in 2020, 2021, we realized the hospital had reported 9 maternal deaths, and perinatal death was at 163. But it was a challenge because maternal death reviews were doing well, but perinatal death were not being reviewed, despite having the high number. So what we did, we had to get engaged and see why. So I'm going to describe the quality improvement successes that we used in order to improve the situation. So at first we began with a problem analysis, and we asked ourselves why? So the 5 whys were used, and we realized that much as maternal death reviews were doing well, actually we're at 100%, perinatal death reviews were not being done,
And we also realized that at the hospital, the MPDSR committee, MPDSR is Maternal Perinatal Death Surveillance and Response Committee, was never constituted with the reason of being understaffed. And we also realized that the maternal perinatal death surveillance and response guidelines were not being effected or supported at the hospital. So, what did we do that we tested to improve the situation? First of all, we engaged the facility leaders in order for them to appreciate the need for this reporting, and we used it to do quarterly performance review where the hospital leadership was engaged. We also agreed with them that let's shift from the monthly and we do weekly maternal perinatal death and surveillance review meetings, which was adopted very well. And at that point, we also constituted a committee, and the members agreed that let's have a coordinator at the hospital level. So, having established those committees and the focal person, we had to orient the staff in the revised maternal perinatal death surveillance and response national guidelines. And this time around, because the HMIS focal person was always saying she's busy, he's busy, we now oriented the midwife who started reporting in DHIS2. Then we also had to hold a joint site review level mentorship, and we conducted support supervision, and this was done in support of Right Southwest staff, and we did a good job. Thereby, we initiated entry of death reviews at the hospital level with the help of the focal person who was selected. That is a pictorial view of the members who had gone for site level mentorship and support supervision. We had the hospital staff, the Right Southwest staff, and myself supporting the facility. When we implemented these changes, we realized that the frequency of the meetings improved, then consistency, timeliness, and the scope of review also improved, because members would pick some reviews and others were neglected. Then number two, we realized that this time around, the perinatal death reviews included macerated stillbirth. Unlike before, where the staff could not think of reviewing the macerated stillbirth. We realized there was improved ownership and accountability for perinatal death. Previously, before engaging the health facility leadership and staff, they were not aware that such perinatal deaths were happening, and this time around, due to continuous engagement, they had to appreciate that indeed they were losing the newborn. We also engaged them in utilizing their data, and every quarter during the meeting, they would present and would appreciate the need to improve on the situation. We also improved support by the hospital leadership for maternal perinatal death surveillance and response activities. In this case, they gave us a focal person who was dealing with that activity. They also gave airtime in form of data for the midwife to enter, and they also gave a laptop for the midwife to do the work. So that was a great achievement. So that is how we moved. At the beginning, we had to hold a performance review and on-site visit where we carried out root cause analysis. And then in the process of beginning, we realized some change. Then later on, with the appointment of the focal person, we had to clear the backlog That's why you see that steep curve. So the midwife was able to enter the reports in the system, and when we cleared the backlog, we started now reducing on the numbers being reported because the death was also, the numbers had reduced. And subsequently, we are now having a sustained reporting because this focal person is ever on lookout with the support from the hospital. What were the lessons learned and what are the conclusions? We realized that constituting maternal perinatal death and surveillance and response committees and conducting maternal perinatal death surveillance and response review meetings at various levels enhances MPDSR reviews and reduces backlog. Teamwork was improved, and accountability for maternal and perinatal death surveillance and response also improved. We also realized that decentralizing data entry reduces delays, especially in DHIS2, and involvement of administrative and political leadership increases community accountability and responsiveness to maternal perinatal death surveillance and response. And those are the people who have been supporting us. I wish to acknowledge their efforts. I thank you so much.
Thank you very much, Christine. That was a very important presentation for not only for the districts, but also for us at national level who are trying to make sure that we functionalize these reviews, especially the newborns. And the issue of backlogs, I think, is a big problem. But I think the interesting thing about Christine's presentation is having a midwifery-led process, which I think is a good lesson we have learned, but we shall discuss that one later. At this point, I want to, so thank you very much. Let's give another clap, please. So I would like now to invite our second presenter, who now will move us to the community. So we are moving from the facility to the community to look at community referral systems by TBAs, which were used to improve the delivery of perinatal health and the outcomes. So thank you very much, Philip Tapem from Nakapiripirit, from Tokora Health Center 4. You have the floor.
Thank you so much, moderator. I'm not seeing our presentation being hosted. I don't know whether there is a tech.
Can you help us, Secretariat, to have the presentation? Maybe you can tell us about yourself as we hunt for your presentation.
Okay. I'm Philip Tapem. I'm a medical officer serving in Health Center 4, Tokora, Nakapiripirit District. For some of us who are deep into the urban settings, Nakapiripirit is in Karamoja region. Okay. I'm here to present an abstract titled Improving Health Facility Deliveries and Perinatal Outcomes Through Strengthening Community Referral Systems by Trained Traditional Birth Attendants as peer mothers. A case of Tokora Health Center 4 already said. I wish to acknowledge the co-authors here. Dr. Godfrey Esiru and then Emina Godfrey. These are members from KUAM who are supporting this presentation. Thank you. A bit of introduction. In the rural settings, the community health referral systems, mainly through the VHTs, are still weak and ineffective. This affects referral of pregnant women for antenatal care and delivery services in the health facilities. So in most cases, like for Tokora Health Center 4, we see cases of most mothers delivering in the community. And as you can see, a bit of problem statement there. For the financial year 2018-2019, we targeted 1,248 mothers delivering in the health facility, but only 36% of them were delivered in the health facility, unfortunately. Meaning 64% of the annual target actually delivered in the community, which is quite unfortunate. Therefore, among other factors, we identified the fact that the mothers in the rural settings still trust the TBAs, the traditional birth attendants, to attend to them rather than being referred by the VHTs and to be delivered by the skilled attendants in the health facilities. Therefore, we identified the need to involve them in the community referral system for better results. Sorry. I don't know why my cursor is not moving.
Maybe the battery. Oh yeah, there you go.
Sorry. So the methodology in the financial year 2019-2020 and then 2020-2021 with support from AMSHIP, the RBF program, Tokora Health Center 4 mapped 30 peer mothers, actual traditional birth attendants trained as peer mothers, in a move to try to involve them in referring mothers to the health facility for deliveries. And then these were trained and oriented on their roles as peer mothers, and each one of them was to identify and follow up pregnant women in their villages and refer them to ultimately deliver in the health facility. Monthly meetings were conducted to review the performance of the peer mothers and share best practices. During these meetings, new lists of pregnant women identified in the villages and through ANC were also exchanged by the midwives and the peer mothers. And then you can see there midwives and the medical officer taking the peer mothers through their roles. A bit of results, as you can see, we recorded increase in deliveries overall from 2018-2019 through 2019-2020, then 2020-2021. The blue plot there showing 2018-2019, and then the red one, 2019-2020, and the gray one, 2020-2021 financial year. To discuss a bit of those graphs, you can see the overall increase in deliveries as shown on the graphs, but some bit of unusual trends to be explained. For the blue graph, from the month of March to June, you can see what appears to be an unusual increase. And this was due to incentives donated by the area woman MP in form of basins, sheets for covering babies, and soap to try to motivate the mothers to deliver in the health facilities. And then also the facility tried to sustain this a bit using the RBF. Then you can also see what appears to be an unusual trend at the start of the financial year 2019-2020. The red plot, which is higher than the gray one, that is month of July and August. This was still the same, the incentives, but also the slow start into the financial year 2020-2021, that is month of July to October, was the impact of COVID-19 pandemic. Tokora Health Center 4 was identified being the highest level facility in the district as a COVID-19 isolation center. The patients deserted the health facility and they feared to come for services across all departments. So you can see that affected also the deliveries as compared to the rest of the financial year, where you see the gray plot generally higher than the red one. We also have some favorable and unfavorable trends in deliveries. Generally, for the months of September to around November, and then February, we tend to record low deliveries in those months. We call that the unfavorable seasonal trend. As compared to the month of December, the festive period, across all the 3 financial years, you can see that December has a slightly higher numbers delivering at the health facilities. Going further, here we are having deliveries and fresh stillbirths in the same plot. You can see the blue bars generally showing the increase in deliveries across the 3 financial years, and then with a decrease in fresh stillbirths. The fresh stillbirths shown by the red line. You can see that this is reversing the natural expected trend. Naturally, you would expect that the more deliveries you have, the more the complications leading to fresh stillbirths as well. But through this project, we were able to reverse that trend, and we felt the benefit of this project. And to paint the picture even better, we also recorded a reduction in fresh stillbirths due to ruptured uteruses. These were fresh stillbirths due to mothers with the fresh and all the previous scars trying to deliver in the community. So these peer mothers helped in referring these high-risk mothers to the health facility to deliver. In the financial year 2018-2019, we had the 3 ruptured uteruses ending up with the fresh stillbirths. And in 2019-2021, we had 1 ruptured uterus. We are proud to report that in 2020-2021, we did not have any mother rupturing due to delay in the community. The peer mothers did us a good job here. Of course, these appear like subtle improvements, but we consider these very, very significant improvements. If you can see even the deliveries, they appear to be subtle improvements, but trust me, there was value for money in this project in terms of survival for mothers and children, and also monetary value in terms of the RBF revenues. This is what I've already discussed from the graphs. I've talked about the general seasonality. I've talked about December being a favorable month and the unusual trends due to incentives provided by the area woman MP. And yeah, I've talked about that. Further discussion, but just bullet number 3, all other factors constant, the results could have been even better if the COVID-19 pandemic did not interfere with the project performance. Yes, you can see, for example, from 2018-2019, where deliveries were around 454 to 670 in the last financial year. These appear like slow improvements, but if COVID-19 had not interfered, trust me, we would have had even better results. So we are proud of what this project enabled us to achieve in the context of COVID-19. Lessons learned: adopting TBAs as peer mothers in the community referral system increased health facility deliveries and improved perinatal outcomes. Point number 2, with data use at the lower level facilities to inform interventions following the quality improvement approach, high impact investments under the health facility RBF program can contribute to improved maternal and child health services. COVID-19 pandemic, this is another thing that we learned, that COVID-19 pandemic impacted negatively the performance of MCH indicators, among other services, of course, in the last 2 years. And we are concluding that with the necessary support, TBAs adopted as peer mothers can contribute to reduction in home deliveries, increase in facility deliveries, and improve perinatal outcomes in rural settings. Yes, I can underline rural settings, because these this is where we have mothers who don't understand reason for delivering in the health facility as compared to the ones in urban settings. If it wasn't for COVID-19 pandemic, the results could have been better. I've already talked about that. We are also concluding that there is still a lot of work to be done in coordinating and strengthening the community referral system in the rural settings with limited communication channels like phones. And the recommendations, rural health facilities should consider working together with the TBS as peer mothers rather than overly criticizing them, so as to expand the community referral base for increased institutional deliveries and improved perinatal outcomes. RBF pre-qualified health facilities should consider similar approaches and innovations as high-impact investments to improve reproductive, maternal, child and adolescent health service delivery and guarantee value for money. Ministry of Health RBF unit and Ministry of Finance, Planning and Economic Development to improve the timing of quarterly RBF releases to enable regular and timely implementation of planned activities like peer mother orientation meetings in the health facilities. Thank you so much.
Thank you.
That is what I had.
Thank you. Let's give Philip a very big hand clap. Philip has exemplified that actually it's possible to work with TBAs, and I think many of us have sentiments, but I think the interesting thing, another interesting thing from Tokora we have seen is that I think they did not experience the typical COVID dip. Many of our healthcare facilities were interrupted in April, but you can see that in Tokora they were able to sustain. And it looks like some of the answers had to do with engaging the communities. And I'm glad also he's talking about RBF now, looking at indicators from the community. I think right now that is the discussion RBF is having to see whether we can actually have some community inputs or results to be able to have a more comprehensive approach. So thank you very much, Philip. Let's clap again for him. All the way from Nakapiripiri. Now let's move to the next presenter. And at this point, I want to invite Patrick. Patrick and Patience will be talking about TB. But to start with, Patrick will be talking about adherence and what happened when COVID came. COVID came and tested our resilience in the healthcare system. And then later on, we shall hear from Patience again concerning TB. So Patrick, you're most welcome. And please introduce yourself and go ahead and make your submission.
Thank you very much, Doctor. Mr. Ogwok Patrick. I trail from Masaka Police Health Center 3 in Masaka City. Our presentation is majorly on tuberculosis. I seek for help on this stuff. I think it's not working. In Masaka, okay, thank you. Okay. As I've told you, my name is Patrick Ogwok, and in this project, I was with Dr. Matthias Tumwebaze. I'm presenting a project, factors associated with adherence of patients on tuberculosis treatment following COVID-19 pandemic at health facilities of Masaka. And the purpose of this was to examine the factors associated with adherence of patients on tuberculosis treatment following COVID-19 pandemic at health facilities of Masaka. The main objective, the specific objective of this, to establish the current level of adherence of patients on tuberculosis treatment, to explore the patient's knowledge on adherence on tuberculosis treatment, also to identify socioeconomic factors affecting adherence, and to establish the health facility factors affecting adherence. Introduction. Tuberculosis, as you know, is an infectious disease caused mainly by Mycobacterium tuberculosis. Apart from that, they can also be caused by Mycobacterium bovis, Mycobacterium avium. The prevalence of tuberculosis is known to be associated with HIV infection, and COVID-19 has affected adherence of TB patients on treatment. TB prevalence in 2019 was stand at 200 persons per 100,000 population in Uganda, and cases notified was at 65,897. The mortality rate stand at 35 persons per 100,000 population. And in Masaka district, a default rate of 18% was reported. Methodology I used, I used the cross-sectional study design and I applied both quantitative and qualitative approaches of data collection. 110 patients on tuberculosis drug were selected from 10 health facilities, and 15 health workers from TB clinic were included in the study. I used the structured questionnaire and interview guide to obtain information. The study was also was approved by TASO, Uganda, and I also sought informed consent from the TB patients. Results of the study. As you can see from that picture, a green part of the table shows good adherence, and the red part of the table shows poor adherence. And adherence is said to be excellent when the person misses at most 0 to 2 tablets of TB drugs. And when it's good, the person has missed 3 to 4 tablets. As others you can see down in the red. In summary, if a person misses 5 and above, is poor adherence, as it is categorized as average, fair, and poor. So the figure above is showing the prevalence of adherence in Masaka. And the prevalence was standing at 86%. The 14% you see is poor adherence. Level of adherence. You can also realize from the pie chart above, more than half of the TB patients, 55% had excellent adherence. And the rest, as you've seen, and 10% of the patients had fair adherence, as you can see from that pie chart. Level of knowledge on TB adherence. From the bar graph, you can see majority of the TB patients, 61.9, had adequate knowledge on adherence on tuberculosis drug. And 12.38, the last, had fair knowledge on adherence on tuberculosis drug, as you can follow from the graph above. From that figure, this is a multiple logistic regression showing the relationship between patient's adherence and factors affecting adherence and multivariate analysis. From that figure, you can see that there is a statistical significance between association between patient's adherence and frequency of counseling at each visit. As you can see, the odd ratio is 15.5 and the p-value of 0.010. You realize that TB patients who receive frequent counseling were 15.5 times more likely to adhere to TB treatment than their counterpart who are not counseled. Also, in the similar table above, you can also realize that there was also a strong relationship found between patient adherence and good conduct of health workers. The odd ratio is 7.0566, and above is the 95 clinical confidence interval, and the p-value of 0.001. Good conduct of health workers was 7.1 times more likely to contribute to adherence of TB patients than their counterpart who are given fair attention. Before I go up, continue, that regression analysis you've seen in the table, it was first passed in a bivariate analysis, and then it was continued to a multivariate analysis. So I decided to portray the multivariate analysis, and that is what you can see. In conclusion, patient adherence to tuberculosis drug was suboptimal at 86% against Ministry of Health set standard of 95. Ministry of Health state that at least for a person to have good adherence, the person must have surpassed 95%. But in Masaka, in the 14 health facilities, it was standing at 86. Also, factors affecting adherence during this time of COVID was stigma, discrimination. As you know, Ministry of Health suspended the transport. You know, this patient moves from the villages to health facility, and they could not move because the security officers were implementing this guideline. And you can also see it contributed to isolation and neglect. In other words, here, when a person coughs in the village, that person is suspected to have what? COVID. And yet the person is having what? TB. So these people ran away from the facility also. And now adherence became an issue. It was also noted that limited medical supplies and TB drugs in private health facilities affected adherence. I wanted to first highlight this point very well. You see, most of these TB patients, before they reach the health facilities, they first go to the what? The private clinics to seek for treatments before they reach the what? The health facilities. In this way, and these private health facilities, they are not treating TB. For them, what they're after is money, which is related to other treatment. Recommendation. Each TB patient is to be assigned 2 treatment supporters, a family member and a VHT. In the direct observed treatment for TB, you realize that the guideline talks about only one what? Treatment supporter, which is the what? The family member. In this aspect, we have realized that when we assign a family member, which the person will mention in the time of counseling, and a VHT, the area VHT where the person stays, this person will be helped. Sometimes even the family member will not help this person, but the VHT will be of help, and this person will not run away from that, from the care. Reinforced counseling by healthcare workers at each visit using local language will also improve adherence. Then district health team to strengthen referral system within health facilities of private and public health facilities. Most times you realize that the supervisions for TB are only men within the public health facilities. Yet, TB patients also seek care in private what? Health care. And they are left out. Health facility to include TB survivor in advocacy services and to create demand for missing opportunity within the community. We realized that when the TB survivor, somebody who has been sick of TB and has healed, has proven to be healed following microscopic examination and has completed the course of TB treatment, either 6 or 8 months, then this person is of good help to help the other fellow colleagues who are also in the same treatment because they have experience of taking TB drugs. They have been taking and they know the side effects, and they can talk better that if you take this drug very well, you're going to get healed, and you're not going to add you more months in their own local language and in their own environment. District Health Department to ensure private clinics are included in treatment of TB and have access to GeneXpert. I need to first ask you this one very, very clear. As in Masaka, I don't know other places, GeneXperts are only located in a government or public facility, with the exception of UCMB or Catholic, these are big, nearly big hospitals that give OPD and outpatient. So, but many of the other small private clinics where patients goes to seek for help or treatment don't have GeneXpert, and they are not bothered to send patients to what GeneXpert site. After all, they are not paid. So they are missed. The patient who goes to those places are missed out. Or if the patient has started the treatment in a government facility or public facilities and found the government facilities far, the person will opt to go to the private or nearby facility.
Patrick, you need to conclude.
The lesson I learned from this study, I learned that a pre-TB treatment counseling on adherence increases patients' ability to take medication consistently, leading to good TB treatment outcomes. I also noted that not involving and supporting private clinics to provide TB services is a very big missed opportunity by the health sector. Most first visit private clinic before going to the government or public facility where TB services are given. Also, we also noted that involving TB survivor in TB treatment would also help to support and increase adherence and retention of TB patients in care. I want to thank the Minister of Health, Masaka Police, and any other person who are here. Thank you so much for attending to me.
Thank you very much, Patrick, and also for the affiliation with the police. I think it gives some more multi-sectoral, multidisciplinary approach here. So I think Patrick has really presented a presentation on a significant problem, the problem of adherence in TB treatment, not only because of the outcome, but also its contribution to other public health issues like drug resistance, and the fact that the COVID disruption had a major impact. And he has made some recommendations. My only concern there was how will the VHT come to the patient when we have tonsil, all those things, but we shall discuss that. I would now like to invite patients to make another presentation again on tuberculosis treatment, and she's looking at the success rate, again, in the context of COVID pandemic. And she'll introduce herself briefly.
Okay. Thank you so much, Chair. Protocol observed. I'm called Patience Bahumwire, working with Kagohe Health Center 4 as the TB focal person, and I'm here to present to you one of the CHUI projects that we implemented over the COVID-19 pandemic period. So there we go. So I will start with a bit of introduction on TB concerning treatment success rate. Sorry, my volume is next, okay, thank you. So tuberculosis has been ranked as one of the leading causes of death worldwide. In Uganda, the National TB and Leprosy Program aims at ensuring that all TB patients notified adhere to to the recommended regimen and complete treatment. So Ministry of Health recommends that a performing TB program achieves at least 90% treatment success rate and 85% cure rate. So when we tried to review data at Kabwohe, a review of Kabwohe Health Center 4 data revealed a TSR of 61.1% below the recommended 90% MOH standard. That data was of July-September 2019, and we tried to look out what was causing the problem. So we realized that, So we looked at the root causes of our drop in the TSR. They were attributed to high death rates and loss to follow-up clients. So the facility initiated a project to improve treatment success rate, July-September cohort, from, of course, the 61.1%. Now we were targeting to hit at least 90% by Jan-March 2020. There we go. That is the method we used. Using a Plan, Do, Study, Act quality improvement methodology, we created a team to identify ways to improve facility treatment success rate and the cure rate because it was so down. So how did we do it? We created a team to make sure at least we maintain our clients on treatment, and then at the end of it all, we get our TSR raised. So each team member, together with VHTs, was assigned TB clients to monitor throughout the course of treatment. The facility created retention, line listing, appointment, and sample follow-up monitoring tools to identify patients and remind staff periodically. And we also had to input in this effective linkage of transfer out through a follow-up call. Through a follow-up call, like if you transfer a case in 1 week period, you make a call to this facility you have referred to make sure that did my patient reach the other facility I referred her to, or she's still home, or she absconded on treatment. So those are the results, but because of time I wanted us to run, and I explained the run chart. So we have seen the change we implemented most was assigning each TB client to a health worker to make sure that this TB client is monitored throughout the course of treatment. So after reviewing our data in July-September cohort, we came up with that 2I project, and we created that team of 6 members who have been following up our TB clients. So when we reviewed data of October, December, after implementing that, we found out that we moved from 61.1% to 82.1% by October, December cohort. Then we continued with that team. By Jan, March, we raised to 100% TSR. So that was a very good 2I. Of course, the results were good. So we maintained our project throughout. We shall see some, on the graph there, you can see some drop from the 100%, but that was contribution of COVID-19 and the lockdown, because some patients now, if we can scroll, let me first finish up with this graph, but if you go up, I will explain why do we have that drop down from the 100% we had attained now to around, I think, 8 there. So after maintaining, we have been monitoring this much as we had set it to January, March, but we have been monitoring it up to this period because we looked at it, the results it gave us, they were so good, raised our TSR. So we can go to the discussion. A total of 180 TB clients were registered from October-December 2019 cohort to January-March 2021 cohort. Of the 108, 01 was an MDR case. Of course, that one we expect the transfer, a linkage to the respective treatment facility. 47 PBCs, 60 PCDs or EP. Then 39 out of 47 the PBCs clients were successfully cured, giving a cure rate of 82.9%. 54 of the PCDs, 60, completed treatment, registering a completion rate of 90%, in turn giving us an average of TSR 87.7%. So why we had some drops up there on our graph here, there between the period of April to June 2020 cohort, the reason was we encountered some dates here. If you can analyze this data, but it seems to be a little bit small, but you will see that I think the month April, June, we encountered some dates and one lost to follow-up. That's why we some kind of dropped from 100 to 80.9%. We go. I'm still on the discussion. So 3 out of 11 were known HIV positive. I'm explaining now why those dates were coming in. 3 out of 11 were known HIV positive. 5 out of 11 were newly diagnosed with HIV, and 3 out of 11 were negative, meaning the deaths, because out of 180 and 8 registered clients, 11 of them, they died. So 8 out of 11 died at the intensive phase of TB treatment, and my work. Okay, there. 8 out of 11 died at the intensive phase of TB treatment, and 3 out of 11 died while at the continuation phase. So you will realize that these patients who are dying within the intensive phase, people who are managing TB clients, you know, that within the first 2 months of treatment, those patients, majority of them, they seek treatment very late. And at some point you may not help. And that is causing us a problem. I will, in our discussion down, there is some request. Meanwhile, of the 3 lost to follow-up, one was a child who was further picked from Kaboe and took to Kampala, and that child, the father denied. So the patient declined on treatment. So the 2 lost to follow-up, the rest of the 2 were reinitiated and on treatment. Therefore, looking at the data above in the July-September 2019 cohorts, 3 lost to follow-ups were registered. They were registered. The interventions employed managed to curb down lost to follow-up, registering only 3 lost follow-up clients throughout October, December to January-March 2021 cohorts. Death rate remained high, above the recommended less than 5%. This is mainly due to HIV-TB co-infection, because we have seen that out of the 11 deaths, 8 of them, they died within the intensive phase, and they were co-infected with HIV. Other factors could include late TB diagnosis, those clients who default on HIV drugs, comorbidities like diabetes, and maybe we have seen also that malnutrition is killing most of our TB patients. Then in conclusion, by assigning TB clients to each health worker, coupled with access to the phone directorate and effective linkage both intra and inter-facility follow-up and documentation, improves TSR and cure rate. What's wrong with this thing? Excuse me, you're taking me back or what? What is happening? Is it me or I'm taking much of the time?
You're on the previous slide, but you need to move faster a bit.
Okay, thank you so much. So one of the recommendations, reliable and consistent funding of TB community-based dots plus effective monitoring of the same. So when you are implementing, throughout this COVID-19 for us, we have been implementing community-based dots with the help of Right Southwest and CAP TB. So we have been implementing that, and we are recommending that if community-based dots are not bothered, like you don't have transport, I will not go to pick the medication, that problem is curbed down. Then there is need for periodic desk audits and data use to make policy guidelines. Here we have seen most of the clients dying. So if you audit the clients who have died, you're able to know, at least you get some knowledge. If I encounter this client of such nature, how do I go about this client? Okay? So, and I'm very grateful that in Shema, around April this year, we conducted, together with the TB coaches for the district and our program officer, they conducted desk audits, and we are at least somewhere as far as desk audits are concerned, where most of our clients are dying. We really have some hint, and we are trying to control some of the issues concerning those dates. LSA facilities to assign TB clients to specific health workers to monitor and support TB clients throughout the course of treatment. This one I give a testimony because it has been working in our health facility. The team that was created is really focused to look out that if I am assigned 3 clients for TB to look out, at least I make sure my clients are maintained within the course of treatment so that they finish the treatment, putting some other, of course, inevitables aside. Then we have LSA facilities need to design local tools that capture key patients' data beyond the MOH regulatory tools. That is very true because, for example, at Kabwe Health Center 4, we have designed some tools to monitor our data. For example, how do we retain our patients in care? How do you monitor, let's say, the PBCs? How do you do those 3 follow-ups periodically? We have designed those tools, and they are helping us so much. Then weekly review of TB data tools by LSA facilities. That is very important. You all agree with me that if you're reviewing your data and your tools, you are able to capture who is missing, who is not updated. Then we have health facilities to encourage teamwork, both within and outside. If you are able to cooperate within and outside, let's say with VHTs, with LOCs, you will be able to get most of the clients online.
Thank you. Patience, we need to wind up.
Okay.
So that we don't
I'm
lose our
actually
audience.
finishing up, but the point I'm emphasizing, those are some of the annexes, the tools we are using to capture the data. Thank you so much.
Okay, you can leave the tools on for those who continue to look at them. You can leave on the tools.
Sorry?
You can leave the tools on the screen so that people can continue studying them. So let's give Patience a very big hand clap. You can see I allowed her to go on because I could see how intimately connected she was with her work. And so let's give her a very big hand clap. The issue of the success rate, they were able to increase success rate in a very short time from 61 to 82%. I think that was a very dramatic increase, and we need to commend them. So, ladies and gentlemen, we are now going to move to the discussion phase, and I want to invite questions and comments. We shall have one round, and if there's a need to have a second round, we will have a second round, but let's try to see whether we have many hands to run a second round. So let's have some comments to the presenters who have done a very good job. We have had very high quality presentations, concise, to the point, and the level of analysis and interpretation, I think, is very, very commendable for this session. So let's have some comments for them. So let me start from this side, and then I'll move anti-clockwise. So let's have 1, 2, 3, 4 on this table, 5, 6, 7 on this table, 8. So we have 8 confirmed questions and comments. Okay, let's start from this side.
Thank you. Good evening, everyone. I'm Chomuka Mapena, Assistant Nursing Officer Midwifery, Kabo Health Center 4. And my question goes to Christine, who has presented about the perinatal death audits. We do the same at Kabo Health Center 4, but we've been having a challenge whereby, like, some mothers come with an IFD, and she delivers like a macerated stillbirth, and you have to go ahead and audit that delivery. But during that form that we fill, there is where they are asking the possible cause of death. And sometimes you try to probe what killed that or what made that mother have an IFD. You find you can't get any because she's not HIV positive, she got all the IPT doses, she attended antenatal regularly, TT she got, but again she gets an IFD. And the form asks you to feel what caused that IFD. Sometimes we would put cause of death unknown, but district supervisors have been telling us that they don't want to see that unknown thing in our reviews. So I don't know how you people of Vivanda have been going about that. So I'm requesting for your guidance such that we can also feel or get those diagnoses and the way how you can go on to probe to get that diagnosis to fill on that form, since they are telling us that we should not feel that unknown again. Thank you.
Thank you. Very good question. Very good question. So let's move behind there. We had 3 hands there.
Yes, thank you very much. Maogule John, Kawaramedo District. Okay. My question goes to Christine. Her presentation was so nice. My first time to hear about perinatal death audit, I was so scared. I thought if they realized that you are the one who caused the death, you might be arrested. So I might believe that even in other places, most health workers may have the same fear How was this overcome in your place? And there is always political pressure when there is a maternal death or perinatal death, whereby the community may have a different view of what caused the death. The health workers may also have a different one. How were you bridging that gap to avoid conflicts? Now, the last is just an appreciation on the TBA involvement. I realized that rural change is a better way of enhancing service delivery other than criticizing. Here we see the case of TBA being changed into peer mothers and being involved in monitoring and in reporting and referral. Thank you very much.
Thank you very much. Let's have the next question.
Thank you very much. Ekelot Isaac from Soroti Region, Assistant Nursing Officer Psychiatry. My first question goes to Philip, and specifically in line with the RBF versus the midwives, because when RBF was brought on board, midwives took it to be midwife issue, and many facilities actually got divided because of RBF, because midwives believed it was their money. So how did you manage as Tokora? And with the project that you were implementing, how did you manage to calm down? Were the midwives getting all the money, or all the facility was getting the money? In other words, in line with the staff incentive. The number 2 is going to Patrick, in line with VHTs versus the facilitation. I loved the issue of a TB client being attached to 2 people. That is a family member and a VHT. What motivation was put in there for the VHTs to keep going to support this client? Because you can find in a village, a client is on the other side of the village. What motivation was given? The last one is going to patients. I love the one of assigning each health worker a TB case. What motivation was attached? Because according to what I know, with the facilities I have reached, TB is left to the TB focal persons. Now here we are, okay, here you are telling us that in Shema, what improved the treatment success rate? You assigned TB clients to each of the health worker. How did you motivate them to come on board to support you as a TB focal person? Thank you very much.
Thank you, thank you. So let's have, I think, the last question there. Is that all? There's a 4th one. Please go ahead.
Okay. My name is Adrawa Nobat from Soroti Region. Mine goes to patients. You did present a very good findings, and you showed to us that about 10% of your patients died. And this is a very big number, and you went ahead to acknowledge that. To that effect, you even did death audits. My thinking is you can do more than death audits. What particular things did you do other than the death audits, such that this occurrence doesn't continue to be what happening in the nearest future? Thank you.
Thank you. So were you just recording the cause of death, or sometimes we are also looking for the avoidable causes of death and we are learning? Okay, let's move to this table. We had 3 hands. There's a there, and then one in the front here.
Start?
Yes, please, go
Okay,
ahead.
thank
Feel
you.
free.
Thank you, Chair. My question goes to Christy. My name is Michael Adrawa, Assistant HMCH Moyo. Christine, just beyond perinatal death review, out of curiosity, have you tried to look at how the response arm is being implemented by a Banda team? Then relatedly, is the review translating it to somehow reduction in perinatal death. I'm just finding out of curiosity, did you try to deep dive somewhere? Thank you.
Thank you, thank you.
Thank you very much. Richard Juko from LPHS Tasso Acholi. Philip, you told us about the engagement of the TBAs. I wanted to understand how the supervision of the TBAs was done and how we did track their efforts individually. Then to Patrick Ogwok, you did tell us that one of the challenges was stigma and discrimination among persons that have TB. And in one of the strategies, you did assign family members to ensure that they follow up. So what are those strategies that we did put across at these 18 sites to ensure that we address the component of stigma and discrimination? Thank you very much.
Thank you very much.
Thank you very much. Presenters, I would like to ask the first presenter, that is Christine. In your presentation, you talked about before you intervene, there were no MPDSR committee formed. But again, you talked about maternal death reviews were ongoing, but perinatal death were not being done. What was the gap? Secondly, I think my colleague already talked about after you constituted the committee, were there improvement in timely notification of these different deaths within 24 hours and the reviews within 7 days? To the gentleman from Nakapirit Pirit about TBAs being turned into peer mothers. How did you do this? Because I know TBAs, they are hardliners. That is part of their work in the community. I believe they are also paid some money by mothers. What strategies did you have to convince these mothers to turn from TBAs into the peer mothers? And also, you talked about referral of high-risk mothers. Were they only targeting high-risk mothers, or you train them possibly to even refer those mothers who really are already in their delivery stage? And then the last one to my friend Patrick from I think talked about a study done in police in Masaka. Good conduct of health workers were directly associated with the good outcome or in terms of adherence. May you please tell us exactly what are those components of good conducts of health workers? Then the last one for you, Patrick, is about TB treatment outcome. You talked about the diagnosis. I'm sure by the time you have your patients, you have already diagnosed them. And the gold standard is GeneXpert diagnosis. Did you come across MDR-TB? And if so, what did you do about it? Thank you very much.
Thank you. We had another one. What was that all?
No, I'm just right here.
Oh yes, we missed
Thank you very much. Good evening, everyone. To the lady from Ankole, the gentleman who has just spoken hinted what I wanted to say, but I wanted just more clarification from you. I was wondering how we're able to review the 5 maternal deaths when, of course, the MPDSR committee has never been constituted, and then even when you don't have the guidelines. So I was wondering how you're able to do that. Maybe you can take us through. And then to my sister, who just mentioned about the unknown cause of death, when you look into the MPDSR guidelines 2017, there's a part that requires you to fill in the cause of death. There's a part that requires, there are about 5 causes of death. The first one I think is trauma, asphyxia, prematurity complications, then congenital anomalies, then to bring you to unknown cause of death, and then others specify. For sure the mothers will come to you and she does not know what happened. You're not going to force her to get a cause of death. She will tell you, I don't know, I just came and I stopped hearing my baby cake. Then what will you say? That you knew the cause of the death? No. Maybe the district leadership may not be taken through on the guidelines. I don't know. The team that is supervising you needs to be taken through the guidelines, and maybe also mentorship on classification of the causes of death. So you're able to do proper reviews, assign the proper cause of death than forging the death. Otherwise, we shall have systems also which have different deaths which are not even into the system. And then also, of course, the guidelines say it is not a blame game. To my brother from Kabera Maidu, yeah, the very first time we were also doing death reviews, people would be put to prison. But later on, when realized, the guidelines state clearly that MPDSR is not a blame game. It is to find the cause of death and then find solutions to that death to avoid the death reoccurring. Thank you very much.
Thank you very much for also taking on some of the responses. So now
Thank you very much.
Oh, okay.
My question goes to the person who presented on MPDSR. I have noted over time that when it comes to maternal death reviews, oftentimes doctors are present. But when it comes to perinatal death reviews, it is left to midwives. And I think it has not been taken as an important aspect. In your district, I don't know what has been done about this issue, and probably it could be the reason why midwives are finding it challenging to point to the cause of death, especially when it comes to antenatal death, that is the macerated stillbirth. What has been done to have the doctors or the more technical people in trying to find out the cause of the death and being part of the perinatal death reviews? Thank you.
Thank you. So we'll now have our presenters make their responses, and I want to request that maybe I begin from Nakaperepirit, since you seem to have fewer questions, and then we'll move on to this side. So over to you.
Thank you so much, our dear audience. I wish to start with the last person who asked about how possible was this, the use of peer mothers. So first of all, convincing them to refer. First and foremost, we mapped these peer mothers using the pre-existing VHTs in their respective villages. Because we discovered VHTs were not referring these mothers, so we tasked them and said, but who delivers the mothers in your village? And they were able to give lists that the other one, they consider the other one to be a champion. They consider, and so we organized a special meeting for all those who were presented as the TBAs from the different villages. And then we talked to them. We talked to them about the importance of mothers delivering in the health facilities, why they shouldn't deliver in the villages, and so on. And then we organized meetings using RBF, allocating some bit of just a transport refund, 10,000. We mapped 30 mothers, so in a quarter we were using only 900,000 to make sure that they come get their transport refund, but most importantly, giving them the lists from the antenatal register, and then also receiving lists from the community. We told each one of them, go around your village. We have manyatas there around like about maybe 50 households in one manyata. Each one of them to make sure that they know who is pregnant in their manyata, about 50 households. So we use them like that. They bring those lists. Then we give them the list from the ANC register, and also telling them this mother has a scar. This mother has this, as a placenta previa. Make sure that she doesn't go into labor in the village. something of that kind. So I think generally, maybe transport refund was enough for them, but most importantly, that responsibility, they felt involved, as opposed to the previous approaches where they were being victimized, being labeled all sorts of names for their actions. So, and then the other one was that you asked whether it was only for risk mother. No, all the pregnant women. We tasked them to refer all the women to deliver in the health facility, not just the high-risk mothers. The other person asked about the mode of supervision and tracking the performance of individual TBS through the monthly meetings. First of all, we maintain the register for all these peer mothers with the mothers under follow-up that they are following. We have a register for them, so we know each one of them has this number of mothers, and then this mother is due for delivery at this time, so we expect them. And we have also their contacts. When we see that maybe they are delaying to refer someone who should have been referred, we alert them. We have a register. And yeah, basically that's how we use, how we track their activities.
Thank you.
And then the gentleman from Soroti asked about RBF, midwives, and then how we manage conflicts. First and foremost, of course, it is the facility leadership to make sure that the matters arising concerning finances are ironed out. But this has to be done in line with the guidance from Ministry of Health. For example, the PS Ministry of Health was very clear that the head or in charge MCH must be the facility RBA focal person, okay? But that doesn't mean all the money goes to. It is the role of the in charge to make sure that they explain why RBF should benefit all health workers, including actually cleaners. For example, the cleaner of the theater should benefit because everyone contributes in their individual capacity. But this aspect of making sure that the MCH in charge takes the lead as the RBA focal person is basically the principle of separation of functions. Yeah, the in charge, your role is to make sure that the activities are implemented as planned, okay, to track activities and to make sure that the funds are not mismanaged. You remain the accounting officer for the health facility, but you empower the midwife who is in charge to make sure that she is able to bring out the priority projects, especially in MCH, where this money should be directed to. So with all that and other modes of grievance handling, you are able to keep the facility in harmony and continue. And then,
okay, so
yeah,
let's keep it short, yeah.
My colleague, Mr. John, was just appreciating the involvement of TBS. I think this is very fine. Welcome, Mr. John. Maybe the other thing I wish to add, sustainability question going forward. The RBF is ending in 2020, December. One could ask, how are we planning to sustain this? We shall use the VHT model. Yes. These TBS can be taken up as VHTs, and they can be sustained using the VHT model, and basically the project can continue. So I think this goes a long way in improving the system. Thank you.
Thank you, thank you. So let's move to Patrick.
Okay.
Keep it short so that we can also.
Thank you very much for the discussion. I'm answering motivation for VHT to work. Yes, in Masaka, Greater Masaka, we have Rakai LSAS project. As you know, every district has VHT. VHT meets every quarter. Like for the program of malaria. Now, Rakai has added them a work on HIV. It is on HIV, that's where TB is added on. So they are motivated when they come for a review, they are given some stipend of transport. So that one makes them motivated. When they're given gloves, gumboots, they feel really they are being recognized somehow. Stigma and discrimination, yes. The reason why we have added on TB survivor to be involved in the treatment is because the TB survivor will explain details of the real cause of the treatment, what he or she experienced at that time to the person who is now going to be on treatment. We as workers, we shall explain in a medical context to somehow, but that person who has been taking treatment has some micro issues he has been undergoing. So if this person explains, it's better heard to this person who is going to be in treatment. Good conduct of health workers. All members who are health workers here can also bear me a witness. TB, most time, is left with TB focal person and some few staff. For my health facility, I'm the TB focal person. This thing, you may talk, but some people don't have that interest to handle TB. Now that COVID came, that time when COVID came in, all of the work was left with the TB focal person. So the good conduct we are meaning here is the attitude of the health workers towards what? Embracing TB as one of the what? A medical condition to be treated. And also embracing TB as integrated services, just like any other health at the facility. Then this MDR, yes, it was unfortunate that in our law facility, we have only identified one MDR case, which was referred to Masaka Regional Referral Hospital, and they were treated from there. As of course, you know, their treatment guideline is almost a bit different from this ordinary local TB we know. So that one, we did not follow it up much. We were only dealing with this one, category 1 and maybe category 2 patients. Thank you so much.
Thank you. So let's have
Okay,
patients.
Thank you so much. I'm answering. My first question was, how did we motivate the health workers to start assigning them TB clients? At first, I said we first looked at the data we had and then formed a team. That team was selected, and of course it was by choice. We first explained the importance of us performing better to the required percentage of TSR. Then the team came up slowly to pick up the importance of us working towards that improvement. Then secondly, what motivated the team, we showed our implementing partner the need to have this team at least facilitated for some activities that will be conducted within the community. And the implementing partner, CAPTB, responded to us. So they have been, the team members implementing those activities have been reimbursed with some car transport and maybe SDA in most of the time. So that's how our team is motivated. But I want to say that if you, the TB focal person, you're really in to do the work and showing the other staff, they pick up slowly by slowly that to know that TB is like any other disease, and if you work on it, you are appreciated by God, your patients, and the rest of the organizations that you're working for. Then, the next question was the 10% of death rate. After conducting a death audit, what else have we done? I want to say that after doing that death audit, of course, we realized some of the causes. For example, we found that malnutrition was contributing some big factors to why these patients are dying. So we are focusing so much on when you are initiating your patient, how is the mark for this patient? How are the kilograms? Is this patient put in the, like you categorize your patient and see which services are needed for this patient. 2, we have seen that some patients, of course, those, especially those who seek medical attention very late, you try to maybe admit and maybe at some point refer this patient, and some of them, they don't even go to the referral hospitals you refer them to. So here you call really we have Ministry of Health representatives to see if they can scale down some of the services, for example, used in monitoring of TB patients, those who are critically ill at health center FOS, to be implemented at health center for us to be easy to monitor some of the patients. You know, TB is the disease of the poor, and most of these patients, when they are critically ill, they don't decide. They are their caretakers that decide. They see sometimes the patient is referred, the caretakers take the patient home to die. So it's my request that if some tests for monitoring TB patients, for example, liver function test, kidney function test, those ones which, if they can be descended to health center FOS, so that at some point we can easily manage our patients effectively from the health center FOS. That is my submission. Thank you.
Thank you. Let's have the last presenter make her comments.
Thank you so much, Madam Chair and colleagues who raised the questions. The first question was, how do we deal with death, especially macerated stillbirth, where the cause is not known? I want to say that it is a challenge across the board, where we do not have the diagnostic equipment at all levels. But I want to encourage you, like at the hospital level, where we have doctors, to work with the doctors and we establish the cause. And where the cause is not established, definitely you can't do much. So we have the Ministry of Health officials, they can take note of that. It is a challenge also to us, especially at lower levels. But that does not stop us from reviewing. Another question that came in was about how did we overcome the fear, especially for perinatal death reviews. I want to appreciate that that fear is cross-cutting, but what we did as Evander District, first of all, was stakeholder engagement. And I want to inform you that at the district level, the performance review meeting during maternal perinatal death surveillance and response, the chairperson is the RDC, and she's always present. We also have the LC5 and other political leaders, the COW inclusive. So what we did was to first orient the district MPDSR committee members, and we tried to share with them the information, and with the information, these people can understand. The information shared would be retrieved from the perinatal death reviews, whereby we would show the perinatal death we had and the cause of death. And these reasons were justifiable, most of them, and they joined us to find a solution. This one made us also to roll down at facility level. As I discussed, at the beginning, getting the facility leadership to join us in review meetings was not easy, as they would say they are understaffed, they don't have time. But with continuous engagement and appreciation of their data, we have them every quarter, and they engage their staff, and now the reception is very positive. Data utilization is the key in neutralizing those issues, and also the MPDSR guidelines clearly state that we are not policing, we are not blaming, but we are trying to find out what caused the death and how can we avert the subsequent death. So with the proper explanation, the fears are allayed, and I want to assure you that you can do it. My colleague, Michael, asked, is this review translating into reduction in perinatal death? I can say partly yes, but this is not so much seen, because we have been struggling with seeing that every death that occurs is reviewed, and people are appreciating the cause of death. So now what we are implementing is looking at how do we reduce this perinatal death and maternal death. But I want to tell you that there is a great reduction, but it is not yet the best. So by the time we come back, probably there will be a big improvement on the reduction. Has it improved on the timely notification? I want to say a big yes, because after realizing that the perinatal deaths were piling and the hospital felt overwhelmed for not reviewing these big numbers, they resorted to do weekly reviews. And in these weekly reviews, it has all the stakeholders that we need on the facility MPDSR committee. And this was came up from the facility themselves. They realized every Monday of the week, they always sit to have their
Recording in progress.
meeting, and they pledged that since we are all meeting to discuss other issues affecting the hospital, why can't we also review issues surrounding maternal and perinatal death? And this has been successful. The medical superintendent, who is the gynecologist, is always in that meeting. And also we have a medical doctor who is also the MCH focal person and MPDSR focal person. So my work has been made easy to capture those people into the discussions. No wonder that's why we have their full support now. So that answers the question of someone who said, how did we manage to get doctors engaged in perinatal death reviews? First of all, before, they had no knowledge about how many children were dying. So when we engaged them in performance review, they realized they have been missing some of the issues or some of the death in their facility. And I want to tell you, after engaging them in data analysis, they came up with what has been the perinatal death that came up as from the mothers who were admitted and those who were from outside. Okay. So now they started looking at how best can they reduce. So the doctors are fully engaged, both in maternal death reviews and also in perinatal reviews. Then how did you, someone raised an issue of how did we review maternal death, yet we were not having guidelines? I want to say that these reviews came in as a result of the trainings that we first had with support from Ministry of Health and our implementing partner. So, you know, when someone is being trained, they tend to pick what is simple. The maternal deaths come in irregularly, so it was easier for them to sit even in a month and review this one maternal death. And the forms were guiding.
And I think the principles are the same.
Yeah. Yeah. So what was hindering majorly the review was because these people were somehow shying away from the bigger numbers of perinatal death. But also the composition of the committee was key. They would always think they are not having many people to join them. But with this weekly review, everybody was on board, and we managed to give them the guidelines, we trained them, and the work was made easy for us. So I want to thank you. I can't narrate whatever we are doing, but there is a lot we did, and the changes are real. Thank you.
Thank you, and feel free, by the way, to interact with Christine in the next 2 days. I want to close this session because it's getting dark, and I want to do I will not attempt to repeat anything, but I just want to summarize the key issues which have come up of this discussion. We have dwelt a lot on the process of learning at the health facility, how we do learning in quality of care. We've looked at auditing. We've learned how people have challenged themselves to do perinatal death audits, even when they were not doing very well in the maternal death audits. So I think learning and tools for learning as a central tool, as a central area for improving quality of care has come up as a main issue. We've also discussed the issue of roles and responsibility and expanding the involvement of other people like the TBAs. We've learned that actually TBAs can be engaged, but also be mindful of the policy to make sure that we don't step over it. But it's possible for us to work with the TBAs in especially those areas where TB births are still very high. And I could see that if we can involve them, and even maybe consider involving them as part of the RBF, there are potentials for improving quality of care and survival of mothers and children. The third issue we have seen here is the role of the community effectiveness. The presentations on TB have shown us that treatment alone, giving somebody treatment alone is not enough, that there has to be adherence, and we have to monitor treatment success, and we have to support the patients. I think the model which is being proposed by the two presenters is encouraging us to support these patients, to link them with health workers. The type of support may differ. It could be emotional, it could be encouragement, but also being able to count and scout these patients seems to improve the adherence and the performance of the program. We have had presenters from all levels, from the districts and the provider level, but also from the police. And I think that combination also has made our session very rich. There are some issues which have kept coming up, and I think we'll need to continue thinking about them in this conference, the issues of motivation, supervision, having data which shows the impact of our quality of care work we are doing. Stigma keeps coming back, although in this country we thought stigma is one of the things we have dealt with. Maybe it's time to revisit the issue of stigma, but also leadership. We've seen what leadership can do and what good leadership can do, and how they can take on very difficult things like auditing perinatal deaths. We will continue in this conference to continue learning on how we can do the perinatal death audits, and I would like to thank Christine. In countries where they have done very well on maternal death audits, they have put more emphasis on perinatal death audits, because a death of a mother is very rare. So if you have been trained to review only death of a mother, and there is no mother in your unit for a year, especially now lower level health facilities, we have learned that most of them, once the mother gets worse, you refer. So most of these people will not be able to practice. So the best thing to do now is to put more emphasis on death reviews for perinatal, for perinatal death reviews, if we are to improve this auditing process. I want to thank you very much. I want to thank you for your indulgence. We have gone over time, so I really want to thank you very much, our presenters, and let's give them a very big hand clap as we close this session. Thank you very much. So, and we'll see you tomorrow in the subsequent sessions. Thank you very much.
Thank you very much, our session chair, Dr. Nsungwa. We appreciate your expertise, experience, and time. We really thank you so much. Can we clap also for all the presenters and all the chairpersons we have had throughout? Allow me surely to thank you so much for your patience to be with us up this moment. It's already late. We appreciate so much. We started late today, and we lost some time in the morning. We hope to really catch up tomorrow. Kindly come a bit early. We want to start by 9, exactly 9, so that we go through and we don't leave late. Tomorrow again, we shall have time to look at the posters, posters which are on the other side. There will be poster presentation around lunchtime. You follow the program. So without, I think, wasting so much time, people are tired, but we really appreciate you so much. Thank you for the good discussion. It has been very lively. We are capturing issues of a secretariat, capturing critical issues, which we need to make a follow-up when we conclude this conference. Have a good evening, stay safe, and see you tomorrow, 9 o'clock. Thank you.